Question number 14. Korava. Question number 14. Laws of extension at which of the following joints indicates injury to the posterior interosseous nerve? First of all, you should know what this posterior interosseous nerve is. Posterior interosseous nerve is a branch of radial nerve. This nerve innervates most of the muscles on the back of the forearm, which are responsible for extension at the wrist and all other joints of hand and digits. However, loss of extension of one of these is quite specific to injury to the posterior interosseous nerve. By answering this question correctly, we learn 25% of upper limb. 25% of upper limb is condensed in this question. It's a branch of radial nerve. It innervates most of the muscles responsible for extension at all these joints. However, loss of extension of one of these is quite specific to injury to the posterior interosseous nerve. Which is that joint and how and why? Any idea? Number? If you say like this, make it like this. Okay. 3. Metacarpophalangeal joint. Alright, then what? Number 1. Proximal interphalangeal joint. Then 1. Now let us see how the extension of all these joints are produced by these muscles. Before that, we shall see the radial nerve. We have already traced the radial nerve to the lower part of the radial groove, and also we saw the nerve piercing the lateral intramuscular septum. I told you, after piercing the lateral intramuscular septum, the nerve reaches the what? Cubital fossa. Now we shall see this nerve in the cubital fossa. This muscle is the brachioradialis. Under the cover of brachioradialis, you see this nerve. Radial nerve has now reached the cubital fossa. What does it do when it is in the cubital fossa? It terminates by dividing into 2 branches. This is the deep branch and this is the superficial branch. The superficial branch runs under cover of brachioradialis, and we have already seen this nerve, also palpated this nerve where? And the anatomical snub box. So the nerve descends like this and leaves the front of the forearm, crosses the anatomical snub box to innervate the skin over the dorsum of hand. What happens to the deep branch? You see a muscle here forming the floor of the fossa. Which muscle is this? Do you know this muscle? Supinator. The deep branch pierces the supinator and comes out as the posterior interosseous nerve on the dorsum of the forearm. So it is the deep branch of the radial nerve that becomes the posterior interosseous nerve. Why this particular branch is given that name, posterior interosseous? Because it runs behind the interosseous membrane. Interosseous membrane is the membrane that connects the radius and ulna here. So a nerve running behind it will be called posterior interosseous, and a similar nerve running anterior to it will be called anterior interosseous. Anterior interosseous nerve is a branch of median nerve. But posterior interosseous nerve is a branch of radial nerve. Now we will turn the forearm to see the back. We will see the back of the forearm. Okay, now we can see the back of the forearm, dorsum of the forearm, posterior compartment of forearm. We can see the same muscle supinator, which is seen both in the anterior compartment and posterior compartment. Now you can see the nerve emerging from it. Now it is called what? Posterior interosseous nerve. This nerve runs in the middle of the forearm. So when we try to reduce fracture of both bones in the forearm, radius and ulna, surgeons often make an incision in the middle of the forearm. So care must be taken not to damage the posterior interosseous nerve. This nerve is in danger. So if you do not know the presence of such a nerve occupying the middle of the forearm, this nerve is likely to be damaged. And this is the nerve supplying all these muscles responsible for producing extension at all joints of the hand and wrist, digits. Now we will see. We have already seen these two muscles in the lower part of humerus. Which were they? We have seen this thing before. Extensor carpi radialis longus and extensor carpi radialis brevis. They are also responsible for production of extension, or producing extension at the wrist. Are they supplied by the posterior interosseous nerve? From the picture, can you try? No. They are directly supplied by the radial nerve when it leaves the spiral groove before reaching the cubital fossa. So these muscles plus the muscles supplied by the posterior interosseous nerve are responsible for producing extension at the wrist. So in this case only the posterior interosseous nerve is damaged, but the muscles extensor carpi radialis longus and brevis are intact. So can you expect loss of extension of wrist joint now? No. Loss of extension of wrist joint will never occur, only it will be weakened, because these two muscles which are directly supplied by the radial nerve in the lower part of the arm are intact. They act at the wrist joint, producing extension. So you can eliminate one distractor from our question. Supinator muscle is supplied by the deep branch. When the deep branch pierces the muscle, it supplies it and then comes out of that muscle as posterior interosseous nerve. And these are the muscles which are directly supplied by the posterior interosseous nerve. You not remember the names of all muscles. They are the extensors of the digits. Which digit has two tendons for extension? Long tendon for extension. Little finger, ring, index, middle finger. Of the four digits, which digit has two tendons for extension, two long tendons for extension? Index finger, because it has a tendon of extensor digitorum and also extensor indicis. That is quite specific for index finger, indicis. So these tendons pass deep to the extensor retinaculum, and to hold the tendon in their respective places, positions, this extensor retinaculum has several compartments. 6 compartments are there within the extensor retinaculum, and these compartments transmit the tendons of long tendons of extensor compartment of forearm. Okay. Now extension of a digit, extension, you want to extend a digit like this, is carried out by 3 muscles. How? Let us see. There is a dorsal digital expansion, a fibrous, triangular fibrous expansion present on the back of each digit. This is also called extensor expansion or dorsal digital expansion, which resembles the hood of a cobra. Hood of a cobra. We have the hood of a cobra on the back of each digit. This extensor expansion is responsible for extending the digit. When the digit is extended, there is extension of both the proximal and distal interphalangeal joints. Both the proximal and distal, there are two interphalangeal joints, proximal and distal, both are extended to extend the digit. How many muscles are attached to this dorsal digital expansion? When these muscles pull the dorsal digital expansion, extension of the digit occurs. Now let us see the muscles which form this expansion. This is a long extensor tendon coming from the back of the forearm, supplied by the posterior interosseous nerve. There are two more small muscles coming from the palm of hand to contribute the formation of this expansion. They are lumbrical and interosseous. So three muscles form the expansion which is responsible for extending the digit both at proximal and distal interphalangeal joints. Let us see the innervation of these muscles. Long extensor, as we have seen before, is supplied by the posterior interosseous nerve. What about the lumbrical? Both median and ulnar nerves. What about interosseous? All interosseae, 8 interosseae are supplied by ulnar nerve only. And lumbricals are supplied by both median and the ulnar nerves. In this case, in our question, only posterior interosseous nerve is damaged. So can you expect loss of extension of digit at proximal and distal interphalangeal joints in this case? No. Why? The other two muscles are intact. They also extend the digit. As long as they are intact, we cannot expect total loss of extension of a digit. Now only one joint remains. Let us go back to the question. Which joint remains now? We have eliminated the wrist already. Thus now only we eliminated both the proximal and distal interphalangeal joints. So which joint remains? MCP joint. This is loss of extension of the MCP joint is quite unique to injury to the posterior interosseous nerve. Wrist extension not lost because the extensor carpi radialis, longus and brevis are intact. Digit extension is not lost because lumbricals and interosseae are intact. But for extending the MCP joint, this is the only muscle. A long extensor alone is required, and that extensor is supplied by posterior interosseous nerve. So by answering this question correctly, we have learned most of the things on the dorsum of the forearm and back of the hand and digits. 25% of upper limb. There is a fascia in the pectoral region between the clavicle and the pectoralis minor. That is why this fascia is called clavipectoral fascia. It is pierced by 4 structures. All 4 are given here, but one is not correct. Which is that one? Is the question. Such a difficult thing to answer. Show your digits from the back. I don't see you people not able to see neutral. Okay. Let us see. Here is the clavicle, and this is the minor muscle, pectoralis. And here is the axillary artery, which is divided into 3 parts by this muscle. This is the first part, this is the second part, and this is the third part. Second part means deep to the muscle. Now you can see a fascia between the clavicle and this muscle. This fascia is the clavipectoral fascia. And this fascia encloses the muscle after coming from the clavicle. Then it extends into the axilla as the axillary fascia. So axillary fascia is the extension of clavipectoral fascia. You can see a large opening in the upper part of this fascia through which 3 structures pass. This is the thoracoacromial artery, a branch of second part of axillary. This vein we have already seen crossing the anatomical snub box and has reached the pectoral region. Such a long vein in the upper limb. Which vein? Cephalic. And the nerve here is the lateral pectoral nerve. But what is given in our question? That is why the problem. In addition to these, lymphatic vessels also pass through this gap. Both the medial and lateral pectoral nerves innervate which muscle? Pectoralis major and minor, both. So these two muscles in the upper limb have dual nerve supply. Pectoralis major and minor both are innervated by medial pectoral and lateral pectoral nerves. Do you know similar muscles in the upper limb having dual nerve supply? Flexor carpi ulnaris, no. Flexor digitorum profundus, correct. Medial half by the ulnar nerve, radial half by the median nerve. So dual nerve supply, perfect. So this is another muscle. Similarly, do you know any muscle in the lower limb having dual nerve supply? Adductor magnus, correct. Because it has an adductor part and hamstring part. Adductor part by the obturator nerve and hamstring part by the sciatic nerve. Similarly, pectineus, femoral nerve and obturator nerve. Several questions have been asked before. The following muscles have dual nerve supply, or the following muscles are composite muscles. Composite muscles are those muscles having dual nerve supply and with having two heads. Okay, here this instead of lateral pectoral, medial pectoral is given. That is why it is incorrect. It's a very simple question. Instead of the nerve that is involved, it is the site of fracture of the humerus that is asked. Which one you want to choose? Number 3. Okay. Look at this. This is the surgical neck of humerus. This is the anatomical neck of humerus. This narrow area where the head is continuous with the shaft is called surgical neck. Why it is called surgical neck? Because it is often manipulated by surgeons. This part of the humerus is often fractured. There is a nerve crossing, winding round the surgical neck of humerus, which is that nerve, axillary nerve. So one reason for injury to the axillary nerve is fracture of surgical neck of humerus. There are two more reasons for injury to the axillary nerve. The other one you are seeing in this picture. What is this? When the humerus is dislocated inferiorly, the axillary nerve is compressed against the long head of the triceps, the only muscle that runs below, and therefore it is damaged. What is the third reason for injury to the axillary nerve? Yes, inadvertent intramuscular injection. If you choose the wrong site for giving injection in the arm, the nerve may be damaged. So there are 3 reasons for injury. One is fracture of surgical neck. Number 2, dislocation of the humerus, as you see in this picture. Number 3, inadvertent intramuscular injection. You know the nerve which is called surgeon's nerve. Which nerve is called surgeon's nerve? Axillary nerve is called surgeon's nerve, because it is often manipulated by surgeons. When they try to reduce the fracture of surgical neck of humerus, this nerve is there. They must be aware of the position of this nerve. They must separate this nerve. Without damaging the nerve, they should reduce the fracture. That is why it is called surgeon's nerve. Just like we call the long thoracic nerve, nerve of Bell, and there are 2 more names given for the ulnar nerve and median nerve. Musician nerve for ulnar, laborer's nerve for median, because the median nerve innervates the muscles on the anterior aspect of the forearm. Most of the muscles in the anterior part of the forearm are supplied by median nerve, which are used for doing manual work or carrying things. So manual, laborious nerve. And the ulnar nerve supplies mainly the small muscles of the hand, which are responsible for producing fine skillful movements of digits required for playing musical instruments. That is why this nerve is called musician's nerve. So the right answer as you have chosen is perfectly correct. Suppose start of the humerus is fractured, injury to which nerve will you suspect? Yes, radial nerve. Lower end of the radius is fractured. Lower end of the humerus is fractured. Ulnar nerve. That is especially the medial epicondyl. Of the three nerves, median, ulnar and radial, which nerve is commonly injured in supracondylar fracture of humerus? Supracondylar fracture of humerus, which nerve is more prone to commonly injured? Median nerve, ulnar nerve, radial nerve. Of the three, which one? Median nerve. All three nerves are, of course, are involved in this injury, but the one which is commonly injured is median nerve, especially its anterior introosseous branch. Anterior introosseous nerve. We will see that nerve later. If you could answer this question correctly, you know another 25% of upper limb. All four statements are correct for the coracobrachialis, but only one is specific to coracobrachialis, unique to coracobrachialis. Number two. Then what? So the digits 4. Okay. Number 4 also. Number 2, number 4. Anything else? Is this the only muscle that originates from the coracoid process of the scapula? Is this the only muscle supplied by the musculocutaneous nerve? Is this the only muscle that inserts on the humerus? Is this the only muscle that flexes the arm at the shoulder? Okay, we will see. Clear these doubts. Let us see the diagram now. This muscle is the short head of the biceps. Just deep to the short head of the biceps we see the coracobrachialis muscle. This is the long head coming from the joint, within the joint, intracapsular. Deep to the short head we see this coracobrachialis muscle. And you see a nerve piercing this muscle. That is how this muscle is identified. Which nerve pierces this muscle? Coracobrachialis. Musculocutaneous nerve. Musculocutaneous nerve pierces this muscle. Which muscle is this? Only 3 muscles occupy the anterior compartment of arm. And posterior compartment of arm, 3 bellies of one muscle. Triceps. That's all. We see one muscle behind, 3 muscles in front. Biceps, coracobrachialis, brachialis are the 3 muscles of the anterior compartment. So we have seen all 3 muscles, and you can see this nerve piercing the coracobrachialis. Musculocutaneous nerve is the nerve of the anterior compartment of arm. That means it supplies all three muscles of the anterior compartment. Not only the coracobrachialis, but also the other two, brachialis and biceps. So that is not specific to coracobrachialis. And we see two muscles taking origin from the coracoid process. Start with the biceps and coracobrachialis. So coracobrachialis is not the only muscle that takes origin from the coracoid process. So that also is not correct. And this is not the only muscle supplied by musculocutaneous nerve. That also we have seen. Now let us see the attachment, distal attachment of these three muscles. This is the site of insertion of which muscle? You must label. Yes, biceps is inserted into the radial tuberosity. And this is called ulnar tuberosity. Which muscle is inserted to the ulnar tuberosity? Also called coronoid process of ulna. Brachialis. Okay, brachialis. So these are the two bones of the forearm, radius and ulna. The brachialis and biceps are inserted into the bones of the forearm. But where is the coracobrachialis inserted into? Middle of the humerus. Of the three muscles we have seen in this compartment, only one is inserted into the humerus, which is that coracobrachialis. Is not something unique to coracobrachialis? Is this not something unique to coracobrachialis? Now, shorter are the biceps, coracobrachialis and longer are the biceps. All three muscles, these three, two sets of the biceps and coracobrachialis produce flexion of arm at the shoulder. Coracobrachialis is not the only muscle that produces flexion at the shoulder, but the biceps also is involved. So because biceps can act at both joints, the reason, there is a separate question we will discuss. As far as the coracobrachialis is concerned, of all four statements, only one is quite specific to coracobrachialis. That is, yes. Only those who know about these muscles, all about these muscles, can choose the right answer. And for others, all four will be the correct answer. Similarly, the biceps also has some unique feature. This question is for that purpose. Which is unique to biceps? Number 4 is the only muscle producing flexion. Number 1, number 3, you see. Other than number 2, that we discussed along with the coracobrachialis, you have chosen the other 3. Musculocutaneous nerve you won't choose because this is the nerve of that compartment supplying all 3 muscles of the compartment. So that is why you have left that musculocutaneous, but the other 3 you have chosen. We will see. We will see. Answer has come. You see here, long are the muscles take in from the scapula, supraglenoid tuberculous scapula. Short taken from coracoid process of scapula. So superiorly the muscle is attached to the scapula. Inferiorly, where is it inserted into? Radius. Does it have any attachment to the humerus? But it crosses 2 joints. Here it crosses the shoulder joint, here it crosses the elbow joint. Therefore, this muscle can act both at the shoulder and at the elbow. It produces flexion of the shoulder and it produces flexion of the elbow also. Because this is the only muscle producing flexion at both joints without being attached to the humerus, the main bone of the 2 joints. That is quite unique about the biceps. Without being attached to the humerus, it moves the humerus at both joints. That is quite specific. And for this question, this is okay. And for this, wrongly placed, you will correct it. No problem. Okay. It acts at the shoulder joint as well as elbow. But no attachment to the humerus. Okay. The chief flexor of the elbow. Brachialis. Brachialis. If you ask an athlete to flex the elbow, immediately one swelling will appear here. The right answer for this question is brachialis, not biceps. Though this muscle is made prominent by the athletes, this is not the chief flexor of the elbow. The brachialis is the more powerful flexor of the elbow than biceps. Biceps comes next to brachialis. And both these muscles are the flexors of the elbow. Biceps. You want to choose biceps for supination? Okay. For sure. How many muscles are involved in supination? No. Brachioradialis has no action of supination or pronation. It is only a weak flexor of the elbow. And this muscle acts during supination pronation in flexing the elbow only. It has nothing to do with supination or pronation. How many muscles are required for pronation? We have seen already. 2. Similarly, there are 2 muscles for supination also. One muscle is known by its action. That is why it is called so supinator. That is one muscle. Which is the other muscle? This is that muscle. Biceps is the other supinator of the forearm. Especially when the elbow is semi-flexed. In this position, it is a powerful supinator of the semi-flexed elbow. You can try. Just semi-flex your elbow, keep the forearm in pronated position. You know how the pronation is? The palm should go down, okay? Should face the ground, not like this. Face the ground. Semi-flexed. Keep the index finger of your other hand over the tendon of biceps in the elbow. You can feel the tendon of the biceps now. Even otherwise, whatever be the position, the tendon of the biceps can be felt. Now, against resistance, you supinate the forearm. Against resistance and feel the biceps tendon becoming more prominent. See that? You can feel. If you do this thing against resistance, biceps becoming more prominent. This is the time the biceps acts. So a powerful supinator of the semi-flexed elbow is biceps. This is its primary action. Biceps is supplied by musculocutaneous, whereas supinator is supplied by deep branch of radial nerve. A single nerve injury can affect which of these movements, supination or pronation? Pronation, correct, because both the pronator muscles are supplied by median nerve. So if median nerve is injured, pronation will be lost. But for the supination to be lost completely, two nerves must be damaged. Musculocutaneous and the radial nerve, deep branch of radial nerve. Only then supination will be lost. A single nerve injury can produce loss or pronation. Of the two movements, supination and pronation, which is more powerful? Is it supination or pronation? Supination is more powerful. That is why this movement is used for tightening a screw. The threads in the screw are designed in such a way that when you turn the screw in clockwise direction, what we actually do, we do supination. We do supination if you are a right-handed individual. That is for tightening the screw. For loosening the screw, that much force is not required. So that is pronation. When we loosen a screw, we do pronation. For tightening the screw, we do supination. So supination, that is, through experience, people have learned supination is more powerful than pronation. Through experience. They do not know whether the biceps is a more powerful supinator or not, but experience has shown. The muscles in the anterior compartment of forearm are placed in three strata. Just like we have three berths in a train, upper berth, middle berth, lower berth, in a three-tier train. Similarly, the muscles are also arranged in three strata, three layers. The muscles of the superficial stratum are all attached to the medial epicondyle of humerus. In other words, the medial epicondyle gives attachment to the common flexors. Similarly, the lateral epicondyle gives attachment to common extensors. So, lateral epicondyle for extensors, medial epicondyle for flexors. So, the muscles placed in the superficial part of the forearm are all attached to the humerus. While doing some surgery near the medial epicondyle, accidentally one of these muscles is damaged. Which is that muscle? Among the several muscles, only one is correct here. This is one muscle placed superficially in the forearm. Number 2, flexor carpi radialis. Number 1. Okay, we will see that now. In this photograph, the 4 digits represent the 4 muscles coming from the medial epicondyle of humerus. Also, you can appreciate in this photograph the site of median nerve. Lateral to the tendon of what? Which muscle? Palmaris longus. Yes. Not only lateral but placed deep as well. Which are the 4 muscles of the superficial compartment, superficial stratum, extending from the medial epicondyle. Let us start from the thumb side. Pronator teres. What is this? Flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Any of these muscles can be injured accidentally if you do any surgery near the medial epicondyle, following fracture of the medial epicondyle, or impeachment of ulnar nerve, as we see in this question. But of the 4, only one is given in that list correctly. Which was that? Exactly, flexor carpi radialis. You can see one more picture. This is again to show you the 4 muscles coming from the medial epicondyle of humerus. You can see the 4 muscles. Not only that, you see the intermediate compartment, the middle berth in a train, is occupied by only one muscle. Which is that muscle? Flexor digitorum superficialis. Flexor digitorum superficialis is unique in that it takes origin from all 3 bones of the elbow. It has a humeral head, ulnar head, and radial head. This is one muscle in the forearm taking origin from all 3 bones of elbow. This is the muscle occupying the intermediate compartment. Now, which are the muscles occupying the deeper compartment, lower berth? In your train, we will see that. You can see the superficialis muscle alone exposed. We have cut and removed the superficial muscles, and superficialis is now exposed. How many tendons arise from this muscle? From the diagram. You need not, turn your face upwards and say, is there in the diagram. How many tendons arise from this muscle? 4 tendons. How far does it extend? Where are they attached to? They are attached to the middle phalanx. Each tendon splits into 2 and they are attached to the middle phalanx. They extend up to the middle phalanx only. Okay. Now we will cut the superficialis to expose the muscles of the deeper compartment. One muscle is already exposed in this picture. This tendon goes to the thumb. Therefore, what term do you suggest for this muscle? Flexor pollicis longus. Correct. You can see the flexor pollicis longus and another muscle which also has 4 tendons. Flexor digitorum profundus. Flexor digitorum profundus. How many tendons arise from this muscle? 4. Up to which phalanx they extend? Up to the terminal phalanx. You can see the tendon passes through the split tendons of superficialis to be inserted into the distal phalanx. Of the 2 muscles, which muscle can act at all joints of the hand and digits? Flexor digitorum profundus. Remember, because this tendon goes up to the distal phalanx, it can act at all joints. But flexor digitorum superficialis can also act at all joints except distal interphalangeal joint. Distal interphalangeal joint. Okay. Now we will remove this profundus also to expose the deepmost muscle in the forearm. Which is the deepmost muscle? Exactly. That we will see now. You can see the pronator quadratus. Supinator is another one. Pronator quadratus is the deepmost muscle. That is how the muscles in the ventral compartment of forearm are arranged in 3 strata. What do you see here? Okay, before that, before seeing the picture, we will discuss about what is the name given to medial epicondylitis. Golfos elbow, inflammation near the attachment of the tendon of common plexus near the medial epicondyle. Golfos elbow. A similar inflammation near the attachment of these tendons to the lateral epicondyle is called tennis elbow. What is meant by student's elbow? Olecranon bursitis, subolecranon bursitis. Why called student's elbow? Once upon a time, students, used, not once upon a time, not now. Students used to spend reading, learning by keeping the elbow like this on the table. Due to constant friction for a prolonged period, the bursa which lies deep to the olecranon process undergoes inflammation. Olecranon bursitis. Nowadays, people, students don't spend that much time to develop this bursitis. And there is one more elbow, student's elbow, golfer's elbow, pulled elbow, tennis elbow, one more elbow, that is pulled elbow. What is meant by pulled elbow? Okay, that's what this diagram showed before. This is a case of pulled elbow. See here, the head of the radius is surrounded by a ring-like ligament called annular ligament. If the head of the radius is displaced either completely or partially from this annular ligament, it is called pulled elbow. This is often seen in young children when their parents try to pull their children by keeping the hand like this, especially when they get into the bus. When they forcefully pull the hand of the children like this, the head of the radius comes out of the annular ligament. Now a swelling is seen in that area, the child cries due to severe pain, and the forearm is kept like this. In which position? Supinated or pronated? The forearm is kept in pronated position. Supination is now not possible. Any attempt to do the supination produces more pain. You can see the head of the radius here forming a swelling in this area. This is called pulled elbow. How this is corrected? It is shown here. Supination is the treatment for this. Pronated forearm is there. You gently supinate the forearm. The head of the radius will fall back into the gap, lumen of the annular ligament. Not immediately, you must give rest to the child is crying like anything due to pain, not able to move the elbow, pronate or supinate the forearm, fixed. You are seeing a swelling here, you must suspect pulled elbow. After that, after giving sedation and other things, you can try this. So flexor carpi radialis is the only one among the 5 given here that takes origin from the medial epicondyle, therefore can be injured. Yes, everything is temporary. If everything is going okay, fine, enjoy it. Something goes wrong, don't worry, that also is not going to last forever. It will also gradually subside after some time. That is life. Muscles flexing the elbow are supplied by A and B. Okay? A and B. That means median and ulnar nerves. Okay. Any difference of opinion? All of the above? I'm going to go with all of them. That means radial nerve also. Okay, we will see. Flexor carpi ulnaris is the only one full muscle in the forearm supplied by ulnar nerve. Which is the half muscle supplied by the ulnar nerve in the forearm? Okay, percentage. So 1.5 muscles in the forearm are supplied by ulnar nerve. This is brachyradialis. Brachyradialis is in fact developmental and extensor. But later it migrated to the ventral compartment. Now it is a flexor of the elbow. However, it carried its nerve supply when it migrated from the extensor compartment, which is the nerve of all extensor compartments in the upper limb. So brachyradialis is supplied by, though it is functionally a flexor, it is supplied by the radial nerve. You see one thing in the upper limb, all muscles responsible for extending the joints in the upper limb are supplied by radial nerve. Any joint, shoulder joint, elbow joint and other joints of the hands and digits. Extension means, even if it is called ulnaris, extensor carpi ulnaris, extension must be given more weightage than ulnaris. So if the other way is ulnaris, okay. Ulnaris means ulnar side, ulnar nerve will supply. Don't think like that. Extensor carpi ulnaris. Extensor should be given more importance. Even extensor carpi ulnaris also is supplied by radial nerve. And all other muscles here in the compartment are supplied by medial nerve. So all 3 nerves innervate the muscles flexing the elbow. Other than our strong flexors like brachialis and biceps. They are the muscles of the arm. These are the muscles of the forearm. All of the above. We have seen 3 muscles in the forearm, sending tendons to the digits. Sending tendons to the 5 digits. Which are the 3 muscles? Flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus going to the thumb. How many tendons are there for the superficialis? 4. How many tendons are there for the profundus? 4. These 8 tendons are enclosed by a synovial sheath. This is what is called ulnar bursa or common flexor synovial sheath, to provide a frictionless environment filled with synovial fluid to lubricate the tendons, and that is why we are able to flex our digits without any friction. See, we are able to do extension, flex and everything is because of the synovial sheath covering the tendons. So 8 tendons are enclosed in one sheath. That is called common flexor synovial sheath. Since the sheath is on the ulnar side, it is called ulnar bursa. Now only one tendon is left. That tendon goes to which tendon, which digit? Thumb. Flexor pollicis longus has its own synovial sheath. That sheath is called, it is seen on the radial side, therefore called radial. So we have 2 bursae in the hand, palm of hand. One is ulnar bursa and the radial bursa, other is the radial bursa. Now what happens when these tendons leave the hand? Before extending into the digits, they leave the synovial sheath and go yellow. They go yellow into the digits. When they extend into the digits, they are covered by their own synovial sheath. Each tendon has its own synovial sheath when each tendon extends into the digit from the hand, from the palm of the hand. Once they extend into the digit, each one is surrounded by its own synovial sheath. This is its own synovial sheath, local synovial sheath. It is totally interrupted from the common flexor synovial sheath. But however, the synovial sheath of one digit, local synovial sheath of one digit, is continuous with the common flexor synovial sheath. Therefore, infection of this digit is dangerous because it can spread easily to the common flexor synovial sheath. Which finger is it, is the question. Little finger? Little finger? But you are showing this digit, that means 1. Okay. Want to go with little finger? Okay, we will see. Yes, you are right. Look at the common flexor synovial sheath covering 8 tendons, and this is the radial bursa covering only 1 tendon. Now, these local synovial sheaths are all interrupted. They are not continuous with the ulnar bursa, radial bursa, but you see the local synovial sheath of the little finger, it is continuous with the common flexor synovial sheath. This is dangerous. So even if a small infection of the little digit, little finger, can easily spread to the common flexor synovial sheath, can produce a very prominent swelling, later abscess in the palm of the hand. So infection of the little finger is dangerous. You can confirm this in the real picture. You can see the common flexor synovial sheath here, and this is the continuation. It's continuous, but here all are interrupted. So all 9 tendons of these 3 muscles, 4 tendons of superficialis, 4 tendons of profundus, and 1 tendon of pollicis longus. 9 tendons pass deep to the flexor retinaculum, plus 1 nerve. Which is that nerve? Median nerve. You can see the median nerve, and you can see the extension of the common flexor synovial sheath in the wrist, and radial bursa also in the wrist. So if you cut the flexor retinaculum here, you will see only 3 structures passing deep to it. One is common flexor synovial sheath, other is the radial bursa, and between them we see what? The median nerve. Only 3 things pass deep to the flexor retinaculum. But if you cut open the synovial sheath, you will see 9 tendons in them. So totally 10 structures pass through the synovial. flexor retinaculum. What is the other term given to that tunnel? Carpal tunnel. So carpal tunnel transmits 10 structures, 9 tendons plus 1 nerve. Or 2 sheets plus 1 nerve, also correct. 2 sheets plus 1 nerve. And you can appreciate from this diagram, the median nerve before entering the carpal tunnel gives a branch here. This branch runs superficial to the flexor retinaculum to innervate the skin over the thenar eminence. What is the name given to this nerve then? Palmar cutaneous nerve. That's all. Palmar cutaneous branch of median nerve. Now from this what do we understand? If the median nerve is compressed within the carpal tunnel, will there be loss of sensation of skin over the thenar eminence? No. That is one important finding in carpal tunnel syndrome. Skin over the thenar eminence will not lose sensation because palmar cutaneous nerve, a branch of median, is given off before the nerve enters the carpal tunnel. You can see that branch now. Therefore, sensation of skin over the thenar eminence will not be affected if the median nerve is compressed within the carpal tunnel. So which digit you want to choose now? Okay. The powerful gripping muscle of hand. Introtibial. Okay, good. Lumbrical, fine. 2, profundus. Now only one thing is left. What is meant by a firm grip? Gripping. You produce firm grip. What you have done? You have flexed all joints of the hand and digits. You have flexed all joints of the hand and digits to have a firm grip. There is only one muscle which can perform this, which can satisfy this requirement, because its tendon goes up to the distal phalanx. Therefore, which muscle could be considered as the chief gripping muscle of the hand? Flexor digitorum profundus. You can see, this is the tendon of flexor digitorum profundus going up to the distal phalanx. The other muscle that comes very close to it in flexing the joints, except distal interphalangeal joint, is they are the gripping muscles of hand. Of the two, the powerful gripping muscle is flexor digitorum profundus. Somebody chose lumbrical. What is the action of the lumbrical? We have already seen the lumbrical taking part in dorsal digital expansion. It can produce extension of the digit. Is it a gripping function? It is anti-grip. Whatever grip you have already also will be lost if you use the lumbrical muscle, because the digit will be extended. You are holding a bucket full of water and you want to try the action of the lumbrical muscle. Bucket will fall down, you will injure your foot, that's all. So, lumbrical is for extending the digit, not for flexing the digit. Introtibial produce adduction and abduction. Like this, spreading the digit, approximating digits are the function of introtibial. Are they required for gripping? No, absolutely not. Gripping means this is a grip. What about the flexion of the wrist? Is it required for firm grip? No. Flexion of the wrist need not be there for having firm grip. In fact, when you flex the wrist after making this grip, it will weaken the grip. Suppose a person is holding a knife. You want to remove that knife from the person. He is trying to stab you. All you have to do is just forcefully flex the wrist. The digits will be extended and the knife will fall down. What happens actually now? When we forcefully flex the wrist, the tendons on the back of the hand are stretched and they pull the digits backwards. Therefore, the digits are extended, grip becomes weak and the knife falls down. So, flexion of the wrist is not required for gripping purpose. It should be in neutral position like this. It is neither flexed nor extended. It should be in neutral position to have a firm grip. For saying single of Siddhartha, that position. Oh, this some of you might have seen already, and for those who haven't seen, just some relaxation in between, some conversation between the mother and the child camel. Oh, yes, you can read. So, skills, knowledge, abilities and experiences are only useful if you are at the right place. Find out where you are now. Infections of hand. Anatomy is required. We have seen two bursae already. Ulnar bursa, radial bursa. They can be inflamed. Ulnar bursitis, radial bursitis. Similarly, the local synovial sheath covering the tendon of the digit also can be inflamed. What is that thing called? Tenosynovitis. That is what is called tenosynovitis. So, ulnar bursitis, radial bursitis, tenosynovitis, plus two more, in fact, one more, pulse space infection, Whitlow, pulse space infection, plus two more spaces are there in the palm of hand. Two spaces are there. One space is in the middle of the palm, the other space is towards the radial side. So we have two spaces also in the palm. They are called mid-palmar space and thenar space. So these are the 6 types of infection of the hand and digits. And we must know to choose the right site. First of all, we should know how to diagnose these conditions. Afterwards, we must know to choose the right site for making incision, for doing IND, incision and drainage of pus. Which one you want to choose for this thenar space abscess? Anatomy, if you know the anatomy, then you will not strain your memory to remember these sites. It will come automatically. Number 3. Okay. Number 1. Then what? You can choose anything you like. You are not going to lose any points. No negative marks here. Number 5 also. Okay. Is it there? Only 4 are there. Non-existing choices cannot be chosen. Okay. You can see the two spaces inside the palm. This is the larger one occupying the middle mid-palmar space. This is smaller occupying the thenar side, therefore thenar space. And you can see from the picture, they all have small extensions towards the digits. You can see that? They extend into the web spaces. You can see these are the web spaces. These two spaces extend into the web spaces through lumbrical canals. Right? So, if we make an incision in the web space, we can easily drain the pus from the web spaces, these spaces, palmar space or thenar space. So, web space must be chosen for draining the pus from the mid-palmar space or thenar space. Now, here is our ulnar bursa, common flexor synovial sheath. This is the radial bursa. If we make an incision along the inner margin of the hypothenar eminence, we can drain the pus from the ulnar bursa. Inner margin, this margin of the hypothenar eminence. Similarly, you can choose the inner margin of thenar eminence also for draining the pus from what? Radial bursa. This is the lumbrical muscle, and this canal is the lumbrical canal through which the palmar space and the thenar space extend into the web spaces. So if you make an incision here, you can drain the pus from the ulnar bursa. If you make an incision here, you can drain the pus from the radial bursa. Right. Now, while making incision along the inner aspects of the thenar eminence, care must be taken not to damage this nerve. You can see the median now after leaving the carpal tunnel, after entering the palm, gives a recurrent branch. This recurrent branch supplies the three small muscles of the thenar eminence, small muscles of the thumb. So, if you do not know the presence of such a nerve crossing the thenar eminence, if you make a deep incision like this, you are likely to cut the recurrent branch. Once this branch is damaged, the three muscles of the thenar eminence will be paralyzed. What will happen to the thumb? Immediately thumb will rotate laterally as we see in the apes. What is that deformity called? Yes, it will result in ape thumb deformity. After draining an abscess, ape thumb deformity. Yes, that should not occur. Now this diagram is showing the sites of making incision for various infections of hand. I will just put the arrow, you have to complete it. Now an incision has been made in the first web space to drain the pus from thenar space. Correct, thenar space is the first web space. You choose other web spaces for draining the pus from exactly mid-palmar space. Because now you know the anatomy. Why we choose the web spaces for this? Because they extend into the web spaces through lumbrical canals. If you do not choose the right site and if you make incision in the wrong site, pus will not come. Blood only will come. And we have chosen the inner margin of the thenar eminence. You must complete it. Okay, perfect. Inner margin of hypothenar eminence. Correct. A local incision can be made like this. A curved incision can be made for what? Pulse space. And you can make one small incision near the proximal end of the digit, one near the distal end of the digit for what? Tenosynovitis. Local inflammation. And this is for the pulp space. I think this diagram is there in your surgery manual. Thus, not something from anatomy. Anatomy linked to surgery. So you must know the anatomical basis of all surgical procedures. That will help you. That will lessen your burden. So all four sites given here as choices are correct for various infections of the hand. Which one you want to choose among the four? Yes. Suppose you want to choose A. What modification will you make in the question? Radial bursa. Number 2. Four-web space. Mid-palmar space. Like that, you can expand this question into several, good number of questions. See, pulp space infection is dangerous because it can result in avascular necrosis of the distal phalanx. Therefore, it must be promptly treated. IND should be done as soon as pus is formed and proper antibiotic must be given to eradicate the infection. If not carried all this out immediately or at the right time, it can result in avascular necrosis of distal phalanx. What is the anatomical basis behind this? Why avascular necrosis in a neglected case of Whitlow? However, a part of the distal phalanx escapes avascular necrosis again due to anatomical reason. Which is that part is our question. Number 1. We will see. Look at the distal phalanx. It is divided into several compartments by fibrous septa extending from the skin to the phalanx. Several compartments are there and these compartments are all filled with fat. That is why, the pulp space if you touch, it is quite spongy due to fat within these compartments. This is the digital artery supplying the distal phalanx. This phalanx is the distal phalanx. After reaching the distal phalanx, this artery divides into several branches. All these branches traverse these compartments to supply the distal phalanx. What happens in pulp space infection? All these compartments are filled with pus. Pus is there in these compartments instead of adipose tissue. This pus is compressing all the digital arteries traversing the compartments. Because of compression of these digital arteries, blood supply to the distal phalanx is cut off. Therefore, it undergoes avascular necrosis. This is the principle behind it. That is why avascular necrosis occurs. However, a small part of the distal phalanx escapes avascular necrosis because that particular part is supplied by an artery which is outside the compartment, which runs outside the compartment. You can see this artery lies outside and it supplies the proximal 1/5 of the distal phalanx. So this part of the distal phalanx escapes avascular necrosis in a case of pulp space infection. It is actually a good sign because ossifying centers are seen in the base of the phalanx. Therefore, bone can grow afterwards. No absorption of digit following avascular necrosis in younger individuals. It will grow. So number 1 is the right answer for this question. Now you know why pulp space infection is dangerous, why it should be promptly treated. If left untreated, what will happen and which part of the distal phalanx can escape avascular necrosis. All these things you have understood now. Orthopedics only. this man has two difficulties. He is not able to abduct the arm. At the same time, he is not able to extend the elbow also. If a person is not able to abduct the arm, injury to which nerve will you suspect? Axillary nerve. If a person is not able to extend the elbow, injury to which nerve will you suspect? So you have to choose both, but only one is the appropriate answer. Therefore, you must choose something common to both. Which is common? Posterior cord. What are the branches arising coming from the posterior cord? You know the tip used for the branches coming from the posterior cord? Ulnar or star. 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 S stands for, this is the posterior cord of brachial plexus. 4 nerves arise from the posterior cord, STAR. S stands for subscapular nerve, upper and lower. T for thoracodorsal. A for axillary and R for radial. So both the axillary and radial nerve are the branches of posterior cord. If the posterior cord is injured, the person will have two difficulties. Extending the elbow becomes difficult. Abducting the arm to the horizontal level also becomes difficult. What is the common cause of injury to the posterior cord of brachial plexus? Crutch palsy, faulty position of crutch in handicapped individuals. If the crutch is not properly aligned in the axilla, it can compress the posterior cord or sometimes the radial nerve directly. Radial nerve injury can occur. Posterior cord injury can occur. Therefore, posterior cord is the right answer for this question. By answering this question correctly, we have understood the 4 branches arising from the posterior cord of the brachial plexus, which can be easily remembered using this tip star, STAR. Number 4. Perfectly correct, because superficial branch of radial nerve, unlike the deep branch, is only a cutaneous nerve. It is a sensory nerve. It cannot produce any muscle paralysis or any disability. It can produce only loss of sensation of skin. It is innervating. That area is this loss of sensation of skin over the dorsum of the hand. Mainly over the first dorsal interosseous, that is the anatomical snub box area skin. Skin of the anatomical snub box area. That area will lose sensation if the superficial branch of the radial nerve is damaged. Deep to which muscle does this nerve descend in the forearm? You remember that muscle which I showed you in the diagram? Brachioradialis, okay. You see, whenever questions like this are asked, giving the details of PIP joint, IP joint, DIP joint, MCP joints, etc., etc., you must concentrate on only one joint, because that alone can give you a clue to your diagnosis. Which is that joint, do you know? DIP joint. DIP means distal interphalangeal joint. Which is the only one muscle that acts at the distal interphalangeal joint for flexing? Flexor digitorum profundus. What is the peculiarity in the innervation of the flexor digitorum profundus? Dual nerve supply. Half muscle by median nerve, half muscle by ulnar nerve. So the part of the muscle supplied by the ulnar nerve will not be paralyzed in this case. The other part will be paralyzed if the median nerve is injured. Then what will be the finding? That is the question. Because this is the only joint movement that could be tested for any nerve injury easily. The movements of other joints, flexions of all other joints like PAP joint, MCP joint, all those things are quite complicated and carried out by muscles supplied by different nerves. Therefore, cannot be chosen for this purpose. Now we will see this diagram. This is the muscle flexor digitorum profundus. How many tendons arise from this? 4. You can see, count the 4 tendons. 1, 2, 3, 4. 4 tendons arise from this muscle. This tendon goes to the index finger. This one goes to the middle finger. These two tendons arise from the lateral half of the muscle which is supplied by the median nerve. Okay. The two tendons going to the index and middle come from the lateral half of the muscle supplied by the median nerve. Now let us concentrate on the other two tendons. This tendon goes to the ring finger and this one goes to the little finger. They come from the medial half of the muscle supplied by which nerve? Ulnar nerve. Therefore, the ring finger tendon and little finger tendon flexion will not be affected if the median nerve is injured in this case. Here our question is about the injury to the median nerve. In such situation, we cannot expect any loss or flexion of the joints of the little finger and ring finger because they are supplied by the ulnar nerve. So let us go back to the question now. Which one will you choose? Except all of you. Now it is very clear. Yes, DAP joints of little and ring finger. Flexion of the DAP joints of ring and little fingers will be lost if which nerve is damaged? Ulnar nerve is damaged. That is the thing. So you must concentrate only on DAP joints whenever you come across questions like this. And that will give you the right picture. You can easily find out the answer. 2 digits by the median nerve, 2 digits by the ulnar nerve. Easy to remember. The nerves arising from the medial cord of the brachial plexus begin with the letter M. Unfortunately, all 5 given here begin with the letter M. But one M is definitely wrong, which is that M. Number 1, musculocutaneous. Where does this nerve arise from? Lateral cord. Okay, we will see. Here is our medial cord, which is nothing but the continuation of the inferior trunk. The nerves arising from the medial cord begin with the letter M like medial pectoral, medial cutaneous nerve form, medial cutaneous nerve forearm, and medial root of median nerve. And the only nerve that does not begin with the letter M, which is the direct continuation of the medial cord, is ulnar. These are the 5 branches of the medial cord. Where is our musculocutaneous nerve? Yes, here it is. From which cord does this nerve arise? Lateral cord. Musculocutaneous nerve is a branch of the lateral cord. Do you know the other nerve arising from the lateral cord? Lateral pectoral nerve. You can see the lateral pectoral nerve here. What is the common cause of injury to the lower part of brachial plexus and its continuation, medial cord? What is that paralysis first of all called? Krumke's paralysis, correct. Similarly, upper trunk injury is called Erb's paralysis. Upper trunk of the brachial plexus injury, that is Erb's paralysis. Lower trunk injury is called Krumke's paralysis. Krumke. Okay. So, subclavicular nerve is not a branch of the medial cord, it is a branch of lateral cord. One of the findings in a medial nerve injury at this site is the pointing index finger. A patient comes to you with his index finger pointed like this. Pointed means extended like this. He is not able to flex the index finger. The flexion of the middle finger also is lost little bit. If you come across a case of pointing index finger, you must immediately suspect injury to the median nerve here at this site. What is the reason for extension of the digit? The muscles responsible for flexing the digit are paralyzed. That is why unopposed contraction of the back muscles results in extension of the digit. Which is the nerve that innervates the muscles responsible for flexing the digit? Median nerve. Median nerve. Which are the two muscles for flexing the digit? Superficialis and profundus. Profundus is the main one because its tendon goes up to the distal phalanx. Correct. For the flexor digitorum profundus to be paralyzed, not the entire muscle, lateral half of the muscle, where exactly the median nerve must be injured? That is the question. In other words, I have simplified the thing. For the flexor digitorum profundus to be paralyzed, where exactly the nerve must be injured? Median nerve must be injured. Middle of the forearm, okay, then what? Near the wrist, upper part of the forearm, in the palm, that you will not choose. Because this is a muscle in the forearm, so can we choose something in the palm? Unlikely. Okay, we will see. Here is our median nerve. When the nerve is in the upper part of forearm, that is in the elbow, it gives this branch. What is the name of this branch? Anterior introosseous nerve. It is the anterior introosseous nerve that supplies the lateral half of flexor digitorum profundus. Where does this nerve arise from? In the elbow. If the median nerve is injured below the origin of anterior introosseous nerve, pointing index finger is never going to be a finding. It should be injured above the origin of anterior introosseous nerve. Only then index finger will be pointed. This is the site. That, in other words, supracondylar fracture of humerus, a common cause of injury. A person develops pointing index finger for in a case of supracondylar fracture, immediately should suspect involvement of anterior introosseous nerve. Or in the upper part of forearm or in the elbow, a penetrating injury damaging the lateral half of the flexor digitorum profundus. This is the only muscle supplied by the anterior introosseous nerve? No, there are two more muscles supplied by the anterior introosseous nerve. You can see this nerve going down to supply the deepmost muscle in the forearm. What is that? Yes, and also a muscle going to the big toe, not big toe, thumb. Okay, what is that? Okay, this is the ulnar nerve supplying the medial half, forget about it. This is the flexor pollicis longus tendon supplied by the anterior introosseous, and pronator quadratus are the three muscles supplied by the anterior introosseous. Therefore, pronation also will be weak in this case. Thumb flexion also will be weak in this case. Because if the proximal part of the median nerve is damaged, it is equivalent to damage to the anterior introosseous nerve. No, because the lateral half of the middle half of the flexor digitorum profundus is supplied by ulnar nerve, and these two digits will be spared only median, the middle and the index finger will be affected. But clinically, we observe only the loss of extension of the index finger. Why not loss of extension of middle finger? Yes, you see, both fingers must be extended logic-wise, anatomy-wise. Because both these tendons go to the index finger and middle finger and they are affected. But clinically, we observe only pointing index finger, not the middle finger. The reason is, you see that, this is the tendon, middle finger tendon. It is closely related to the ring finger tendon and by several tendinous lips extend between them. The ring finger tendon is normal in this case because it is supplied by ulnar nerve. Only middle finger tendon innervated by the median nerve is affected. So, but since this tendon is connected to the ring finger tendon by several tendinous lips, that tendon does not allow this tendon to be stretched. That is why middle finger is not pointed here. The middle finger cannot be stretched because the tendon is not stretched by, not allowed to stretch because of its connection, intimate connection with the ring finger tendon. Now it is clear? Okay. Lunch time. ദാസൻ നിൽക്കുന്നത് അതിന് വേണ്ടിയിട്ടല്ലേ? ഒരു 5 മിനിറ്റ് കൂടി കഴിഞ്ഞിട്ടാവാം. So only when the median nerve is injured in the upper part of the forearm, this will be a finding. And in the case of carpal tunnel, all these things, this pointing index finger or in the wrist, if the nerve is injured in the wrist or in the carpal tunnel, pointing index finger will never be a finding. How will you differentiate the median nerve injury within the carpal tunnel or outside the carpal tunnel from outside the carpal tunnel? If it is within the carpal tunnel, sensation of skin over the thenar eminence will not be lost. All our findings will be there. If it is outside the carpal tunnel, this also will be a finding. Near the wrist, pointing index finger will not be there, but loss of sensation of skin over the thenar eminence plus all the findings of the carpal tunnel syndrome will be there. Right? That is how we can differentiate the level of lesion of the median nerve. Median nerve can be injured in 3 places. One is near the elbow in supracondylar fracture of humerus. The other one is in the wrist due to a penetrating injury or a cut injury. Third one is in carpal tunnel syndrome. These are the 3 sites of injury to the median nerve, and you should know how to differentiate the 3 types of injury. It's mainly orthopedics based on anatomy. This is a very simple question. Now I expect all of you to answer this question correctly. Which of the following passes through the carpal tunnel? 2. Yes, we have seen already 9 tendons plus 1 nerve. We will see them again. This is the only one tendon going to the thumb. That is flexor pollicis longus. And 8 tendons are enclosed in one sheath, that is the common flexor synovial sheath, with 4 tendons of superficialis and 4 tendons of profundus. So 8 plus 4 plus 4, 8, 8 plus 1, 9. And the only nerve that passes through. Does the ulnar nerve pass deep to the flexor retinaculum? Does it pass superficial to the retinaculum? It is neither deep nor superficial, It passes within the carpal tunnel, within the flexor retinaculum, because in this area the flexor retinaculum splits into 2 layers to enclose the ulnar nerve. That area is converted into another tunnel. What is that called? Guyon's tunnel. So ulnar nerve is involved in Guyon's tunnel syndrome. I could have shown you that thing in the previous picture. Let me see. To make it clear. Look at this picture. Here the median now is not visible in this area because it passes deep to the flexor retinaculum. Even the ulnar nerve also is not visible. Suppose it passes superficial to the retinaculum, it should be visible here. It is not visible. You know why? Because here the flexor retinaculum splits into two layers to enclose this nerve and converting this area into another tunnel called Guyon's tunnel. And when this nerve is entrapped within this tunnel, that syndrome is called Guyon's tunnel syndrome. It is neither superficial nor deep. Ulnar nerve pathway. Not visible here. It goes between the two layers of the flexor retinaculum. So, circus passing through, that is the flexor retinaculum. You can see the flexor pollicis longus tendon and the other 8 tendons plus the median nerve. These are the things passing through the carpal tunnel. Totally 10, but if you expose this area, you will see only 3. 2 synovial sheath and the nerve between them. We will, okay, with this we will, we will stop here. We will discuss this question after lunch break. We will have 30 minutes lunch break and assemble after 10 minutes. You need more than that? Maximum 45 minutes. So if you don't start early, it is difficult to finish all the questions. So we shall begin with question number 32. We know more than 75% of lymph from the breast is drained into the axillary lymph nodes. These are the 4 groups of axillary lymph nodes as per Walter classification. Of the 4, which one receives more than 75% of lymph from the breast directly? Drain into which group of axillary lymph nodes first? As per our present day classification, it is level 1 group, lower group. Which is that lower group among the 4? Number 2. Sure. Pectoral. Okay, we shall go with that. The breast is divided into 4 quadrants to describe the drainage of lymph. These are the axillary lymph nodes which drain more than 75% of lymph from the breast, especially from the upper outer quadrant, and partly from lower outer quadrant. The lymph first reaches the level 1 group, that is pectoral. So it is the pectoral group that receives the lymph directly from the breast in the beginning, more than 75%. Then the lymph reaches the middle group, that is the central. Then the lymph reaches the apical group. And from there it reaches the supraclavicular lymph nodes. Some lymph reaches supraclavicular also. In this way, 75% of lymph from the breast is drained into the axillary lymph nodes. As per our present classification, the pectoral group comes under which level? You know that? Level 1. That is level 1 lower group. Central group is the middle group. Level 2. Apical above, therefore upper group, level 3. If the right breast is involved, the lymph finally reaches the right lymphatic duct where it meets the bloodstream. If the left breast is involved, the lymph finally reaches the thoracic duct where the thoracic duct meets opens into the jugulo-subclavian junction, that is the junction between the internal jugular vein and subclavian vein. It is here the thoracic duct opens, and it is here the lymph in our body meets the bloodstream. %20 of lymph from the breast, especially from the medial half of the breast, this side, medial half, is drained into parasternal nodes, also known as internal mammary nodes. Not only of the same side, but also of the opposite side, because the lymphatic vessels cross the midline behind the sternum to reach the parasternal nodes of the opposite side. Therefore, whenever you come across a case of malignant tumor affecting the medial part of the breast, you must always examine the opposite breast, because opposite breast also may be involved because of this crossing. Lymphatic vessels cross and cancer cells can reach the opposite breast also. 5% of lymph from the breast, especially from the lower outer quadrant, is drained into the posterior intercostal nodes. 5% only, especially the lower outer quadrant. So 75%, 20 plus 5, 100% over. However, a small amount of lymph from the breast, especially the lower inner quadrant, a small amount is drained into the abdominal cavity. How? Through the subperitoneal lymphatic plexus and subdiaphragmatic lymphatic plexus. That's how the lymph reaches the abdominal cavity. Though it is a very small percentage, sometimes it is dangerous because cancer cells traveling through this route can reach the abdominal cavity and can be dropped down into the pelvis, resulting in secondaries of pelvic organs, especially the ovary. And this type of tumor we have studied in gynec, what is called Krukenberg tumor. Yes, Krukenberg tumor can occur. Krukenberg tumor of ovary can occur due to metastasis, distant metastasis. This is all about the lymphatic drainage of breast. 75% to the axillary, 20% to the internal mammary, 5% to the intercostal, and some amount goes to the abdomen also. So we shall go back to the question. We shall see the right response. Pectoral group, also known as anterior group. This is the group that lies below the pectoralis minor. This woman's complaint is numbness of skin over the thenar eminence. Immediately you should suspect injury to this nerve. Which nerve? Median nerve. So after knowing this, you must read the choices. Which of these findings will confirm the most likely diagnosis? It is a case of median nerve injury because there is loss of sensation of skin over the thenar eminence. Also indicates injury to the median nerve near the wrist or outside the carpal tunnel. That also indicates injury to the median nerve outside the carpal tunnel before it enters the carpal tunnel. Okay, which of these will you choose? Korpella. 4 you want to choose. Okay, we will see. Atrophy of dorsal interosseous muscles we can easily eliminate because all interosseous, whether they are dorsal or palmar, irrespective of whether they are dorsal or palmar, are supplied by ulnar nerve, so we can eliminate. Weakness of extension of the thumb. Extension of the thumb, we have already seen the tendon responsible for extension of the thumb. Extensor pollicis longus and brevis. They are seen on the dorsal aspect. And which nerve supplies these two muscles? Radial. So you can eliminate the radial nerve also. Loss of sensation of skin over the medial aspect of hand. Medial aspect of the hand is innervated by ulnar nerve, so we can eliminate that also. What is this particular movement? If we want to compress something between the thumb and little finger, what is required? Opposition. Opposition movement is required. Only when the thumb is approximated with the little finger, we can keep something between these two digits. This is achieved by the contraction of one small muscle forming the thenar eminence. Which is that muscle? Pollicis. It is neither longus nor brevis because there is only one muscle, so we need not use this adjective. Simply opponent. It's a problem here. This muscle is supplied by the recurrent branch of median nerve. So this is in favor of injury to the median nerve. What happens if this branch is damaged? The thinner muscles undergo atrophy and wasting of the thinner eminence occurs after some time. Once these muscles are paralyzed, the thumb is turned laterally, rotated laterally as we see in apes. That is why this deformity is called ape thumb deformity. Also ape hand deformity, both are one and the same. Inability to oppose the thumb is an important finding in median nerve injury. The person finds it difficult to hold a card between the thumb and the index finger. Card between the thumb and index finger, which contraction of which muscle is responsible for this? Adductor pollicis, correct. It is a deep muscle in the palm of hand. Though it has the name pollicis, it is supplied by ulnar nerve. So this is the muscle that is paralyzed, or it is responsible for keeping something between the thumb and the index finger. Definitely adductor pollicis, no doubt. Yes, ulnar nerve is injured behind the medial epicondyle. These are the findings. One is not correct. Choose that one. Number 3. Anything else? Impairment of ulnar deviation of hand. This is ulnar deviation. If you flex your wrist towards the little finger side, it is ulnar deviation. Towards the thumb side, it is radial deviation. Two muscles are required for ulnar deviation. They are one muscle from the anterior compartment, one muscle from the posterior compartment. Muscle from the anterior compartment is flexor carpi ulnaris, and the muscle that runs behind this, a corresponding muscle, extensor carpi ulnaris. These two ulnaris, when they contract together, ulnar deviation is produced. Similarly, radial deviation also, you see, which muscle responsible for radial deviation on the anterior side? Flexor carpi radialis. On the posterior side, extensor carpi radialis, longus and brevis, both. 3 muscles are required. Now, flexor carpi ulnaris is supplied by ulnar nerve. What about extensor carpi ulnaris? Radial nerve. That is why in this case, there is impairment of ulnar deviation. Ulnar deviation is not lost totally, cannot, because extensor carpi ulnaris is still functioning. So this statement is perfectly correct. Impairment of ulnar deviation of the hand will be definitely a finding in ulnar nerve injury, no doubt. The loss of flexion of the DIP joints of ring and little fingers, perfect, because we have studied the medial half of the flexor digitorum profundus sending tendons to these 2 digits is supplied by median nerve, ulnar nerve. Therefore, that also will be a finding. Loss of adduction and abduction of medial 4 digits, spreading and approximating the medial 4 digits. This is due to the action of all introsei, both for palmar introsei and for dorsal introsei. All of them are supplied by the ulnar nerve, therefore this will be a finding. But loss of sensation of skin over the lateral side of ring finger, that is not correct. Look at this diagram. Okay, this is to show you a case of supracondylar fracture of the humerus affecting the ulnar nerve. Okay, leave it. This will be definitely a finding. You see, the entire little finger and medial half of the ring finger, not the lateral half of the ring finger. The 3 and a half digits on the lateral side, lateral 3.5 digits are innervated by the median nerve. Medial 1.5 digits only are innervated by the ulnar nerve. That means the entire little finger and medial side of the ring finger, not the lateral side of the ring finger as given in that question. That is the reason why it is not correct. Plus ulnar claw hand also will be finding due to involvement of some lumbricals and all introsia. What is this quadrangular space? You see, muscles extending from the scapula to the humerus form spaces between them, extending from the scapula to the humerus. We have seen already two muscles, teres major and minor. They come from the lateral border of the scapula, they go to the humerus. And these muscles intersect with the long head of the triceps. And that area is now converted into three spaces. One large quadrangular space and two triangular spaces. Neurovascular structures pass through these spaces. Surgeons manipulating this area often reach the site of fracture of the humerus by going through these intermuscular spaces. While they manipulate these spaces, they should take necessary care not to damage the neurovascular structures passing through them. Here our question is about the quadrangular space. Which structure will you expect if you explore the quadrangular space? That is the question. Which one you want to choose? No idea. Axillary nerve? Okay, we will see the spaces instead of describing. If you see the diagram, it will be there in your mind easily. Look at this. The teres minor and teres major, they extend from the scapula. They intersect with the long head of the triceps, converting this area into three spaces like quadrangular space, lower triangular space and upper triangular space. You take 2 digits of your one hand, 2 digits of your other hand, just keep it like this. You can convert them into 3 spaces. 2 digits of one hand, 2 digits of other hand. If you just keep like this, for others to see from there, for you. You can convert them into 3 spaces. The 2 digits of one hand represent the teres minor and major. The 2 digits of the other hand represent the humerus and the long head of the triceps. Now the boundaries are very clear. That is how these intermuscular spaces are formed. Suppose there is a fracture of the cervical neck of humerus. Surgeon wants to reduce the fracture, internal reduction. How can we reach that area? Only by going through the quadrangular space. He cannot cut the muscles to reach that area because the muscles have the function of a surgery. So they go through the quadrangular space to reach the site of fracture and complete the surgery. Similarly, there is fracture of shaft of the humerus. How can we reach the area shaft of humerus? Only through the lower triangular space. So when they manipulate these areas, they should take necessary care not to damage the neurovascular structures. That is the reason why we want to know more about this. Now we will see the structures passing through these 3 spaces in another diagram, right? Okay, there is a notch here in the upper part of the scapula. What is it called? Suprascapular notch or simply scapular notch. Enough. This picture shows the structures passing through all these things. Here is our quadrangular space. What structure is crossing this space, passing through this space? An axillary nerve, accompanied by posterior circumflex humeral artery. These are the two structures passing through the quadrangular space. Surgeons should take necessary care not to damage them while manipulating the surgeon's nerve. In this picture you can appreciate the axillary nerve supplying two muscles. It gives branches to the deltoid, you can see that. Also it gives a branch to the teres minor. Yes? So two muscles are supplied. Also it gives a cutaneous branch. You can see that that branch goes to supply the skin over the deltoid. Do you remember the name of this nerve? Upper lateral cutaneous nerve. So that is the reason why whenever axillary nerve is damaged, in addition to muscle paralysis, there will be loss of sensation of skin over the deltoid. That is an additional finding. Sensory loss also will be there. The person won't be able to abduct the arm to a horizontal level. The prominence of the shoulder will be lost. And what is that condition called? Drooping of the shoulder. The shoulder will be flattened. This prominence in athletic individuals, if they do like this, two bulgings will appear from this side. Two bulgings. Only in athletes, not in us. And that is the deltoid. That prominence will be lost if this nerve is damaged. Flattening of the shoulder or drooping of the shoulder. Now we can see the lower triangular space. This space also is related to two structures, one nerve, one artery. Artery is this, profunda brachiae, a branch of brachial artery. First and the largest branch of brachial artery. This artery accompanies the radial nerve along the radial groove. So radial nerve and profunda brachiae artery pass through the lower triangular space. So in order to reduce the fracture of the shaft of the humerus in this area, the surgeon should explore the lower triangular space. Here is the upper triangular space. It is related to one artery only. One artery winds around the scapula and anastomosis with the suprascapular artery. Do you remember that artery? Circumflex scapular artery in the scapular anastomosis, clearly shown in this picture. This is the suprascapular notch, and in the living it is converted into a tunnel, a foramen, by a ligament which bridges the margin of the notch. Now through the foramen nerve passes, and above the foramen artery passes. Artery above, A, both are A. You can easily remember. Artery above. Nerve through. And this suprascapular nerve runs deep to the supraspinatus, giving branches to the supraspinatus, also to the infraspinatus. Both the spinatus muscles are supplied by suprascapular nerve. Okay. Now the right, okay, one more diagram to show the same thing. You can see the axillary nerve and the accompanying vessel. You can see the radial nerve and its accompanying vessel. Also you can see a long branch going to the unconeus muscle from the radial, from the upper part of the radial nerve. So axillary nerve is the right answer for the question. Suppose you want to choose the radial nerve, what modification will you make in the question? Lower triangular space, easy. Yes, we have seen the cephalic vein twice before. We have seen this vein piercing the clavipectoral fascia. Then what does it do? It ends there. It ends in which of these veins? Axillary vein, You can see this vein occupying the gap between the deltoid and pectoralis major. That is why this groove is called deltopectoral groove, which can be seen in some individuals clearly. Deltopectoral groove. Then it pierces it is related to the coracoid process. Deltopectoral groove is related to the coracoid process. What the surgeons do when they reduce the inferior dislocation of the humerus, they separate the two muscles to expose the displaced head of the humerus in that groove area. Whenever the head of the humerus is displaced downward, this groove, deltopectoral groove, is related to the head of the humerus. Normally, in all normal individuals, it is related to the tip of the coracoid process. But once the head of the humerus is displaced, if you separate these two muscles, deltoid this side, pectoralis major this side, you will see the head of the radius over there. Head of the humerus over there. Now, this vein pierces the clavipectoral fascia and ends in the axillary vein. Don't say subclavian vein. Subclavian vein and artery are seen above the clavicle. What we see below the clavicle are the axillary artery and axillary vein. And these veins, this vein and artery are supported, protected by one muscle which lies just beneath the clavicle. Which muscle it is? Whenever the clavicle is fractured, the fractured ends of the clavicle can easily damage the axillary vessels, but they are not damaged because of this muscle. It acts as a cushion protecting these vessels from injury by the cuttings of the clavicle. Fractured ends of the clavicle. Which muscle is this? Subclavius. That is one action of the subclavius. So axillary vein is the right answer for this question. Yes, everything is there in the question itself. It is a definite case of radial nerve injury following fracture of the humerus, shaft of the humerus. Which of these findings will confirm the nerve damage? You should be in a position to eliminate all the distractors to arrive at your diagnosis. Can you expect weakness in pronating the forearm? Yes or no? Because pronation means pronator teres quadratus supplied by? Yes. Weakness in flexing the elbow. Flexion of the elbow is mainly carried out by the biceps and brachialis. Both are supplied by? So eliminate. Numbness over the lateral 3.5 digits. That is the nerve median. So you can eliminate. Inability to oppose the thumb. Oppose the thumb, just now only we studied. Opponent's pollicis, again median nerve. What is this thing? Inability to extend the wrist. Wrist drop will be a finding wherever the radial nerve is damaged, irrespective of the site of that. Wherever the radial nerve, means the trunk of the radial nerve, is damaged, wrist drop will be a finding. As you see in this picture. You see what happens when the humerus is fractured? The nerve gets caught between the two fragments and crushed. So what happens? Wrist drop, inability to extend the wrist due to paralysis of all extensor muscles of the forearm. Also some extending from the lower part of arm. This we have already discussed. I expect all of you to answer this question correctly. Number. Okay. Posterior cord. The person is falling from a height. Luckily, on the way, he could catch hold of a branch of a tree to break the fall. But this results in sudden and violent hyperabduction at the shoulder, damaging a part of the brachial plexus. Due to damage to this part of the brachial plexus, there is pain and loss of sensation or tingling sensation, numbness, etc. along this part of the upper limb. Which part of the upper limb is the question. So you should know two things to answer this question. First of all, the part of the brachial plexus that is involved when there is sudden hyperabduction at the shoulder. Number two, the area of distribution of that part of the brachial plexus. If you know these two things, you can answer this question. This is the situation. This part of, here there is violent stretching. This is, the upper limb is forcefully separated, violently separated from the trunk, putting undue stress at this point, and this damages a part of the brachial plexus. This can also happen when you pull the hand of the baby at the time of labor before the rest of the body comes out. What type of paralysis can it produce? Yes, paralysis, Klumpke's paralysis, that means lower trunk injury. Look at this picture. The hand is pulled before the rest of the body comes out. The head gets stuck here, not coming easily, hand presentation. You are pulling the hand forcefully. This part is unduly stretched. And complete claw hand has occurred. So what paralysis it is? Klumpke's paralysis. Lower trunk injury. Lower trunk injury means medial cord of brachial plexus. Medial cord of brachial plexus means medial cutaneous nerve of arm, medial cutaneous nerve of forearm, ulnar nerve. So there will be pain or numbness or loss of sensation along the medial aspect of the entire upper limb due to involvement of lower trunk of brachial plexus, just like we have seen with the cervical rib. They are also stretching, here also stretching. So the lower trunk is involved, medial cord and all these things. That means could be the entire lower upper limb, but part of the upper limb also may be involved, as we see in the choices given. Which among them you want to choose? Exactly. Medial aspect of the forearm, may not be forearm, arm, forearm, even hand radiating to the ring and the little finger, depending on the severity of the injury. Injury to the musculocutaneous nerve can produce the following. Musculocutaneous, nerve of the anterior compartment of arm, supplying three muscles. Pardon? Number 4. You want to choose number 4. Weakness of flexion at the elbow. How will you explain? Due to paralysis of biceps and brachialis. Okay, perfect. Weakness of supination. How will you explain? Because biceps is a powerful supinator of the semiflexed forearm. So that also is a possibility. Loss of sensation on the lateral aspect of the forearm. How will you explain? For that diagram is required. Look at this musculocutaneous nerve. This nerve, after supplying these three muscles, continues as the lateral cutaneous nerve of forearm. That is why this nerve is given that name. After supplying the muscles, it becomes cutaneous, musculocutaneous. Hence the term musculocutaneous. Which part of our forearm is innervated by the musculocutaneous nerve? Lateral aspect of the forearm. That is why it is called the lateral cutaneous nerve of forearm. So there will be loss of sensation along the lateral aspect of the forearm also. Loss of adduction at the shoulder. How can? The three powerful adductors are there. Pectoralis major, teres major, latissimus dorsi are there. They are the powerful adductors of arm at the shoulder. As long as they are intact, this coracobrachialis and sartorial biceps are weak adductors. They cannot do anything. So loss of adduction is not a possibility. Do they take origin from the tendons of flexor digitorum profundus? Do they take part in dorsal digital expansion? Are they supplied by both the median and ulnar nerves? Let us see. Lumbricals, worm-like. That is why we call the roundworm Ascaris lumbricoides. That lumbric. This muscle is peculiar in that it has no bony origin and no bony insertion. Though it is a skeletal muscle. It takes origin from the tendons of four bellies are there. They take origin from the tendons of flexor digitorum profundus. And inferiorly, as in the diagram superiorly, but in anatomical position inferiorly, they are all attached to the dorsal digital expansion. Since these muscles are attached to the dorsal digital expansion, they are associated with the extension of digit. At the same time, they can produce flexion of MCP joint. You want to call a person like this. This is the action of lumbrical. What we do, we flex our MCP joint and extend our interphalangeal joints when we call a person like this. Come on, please come. So I say, MCP joint is flexed and interphalangeal joints are extended. This is the primary action of lumbricals. Lumbricals, medial to lumbricals are supplied by, since they are placed medially, they are supplied by ulnar nerve. Lateral to lumbricals are supplied by median nerve. These lumbricals are numbered from thumb side, not from the little finger side, thumb side. Thumb side, first lumbrical, second lumbrical, third lumbrical, fourth lumbrical, like that. They are numbered from thumb side. So in that way, the medial to lumbricals means third and fourth lumbricals. Lateral to lumbricals means first and second lumbricals. So first and second lumbricals are supplied by median nerve. Third and fourth lumbricals are supplied by ulnar nerve. In one way, these muscles on the upper limb also have dual nerve supply. As far as single belly is concerned, only one nerve, but if you combine both median and ulnar nerves, innervate. But what is given? They extend the MCP joints and flex the IP joints. That is just the opposite. Therefore, this is incorrect. Very simple. It is a case of ulnar nerve injury. Of the four choices given here, only one innervated by ulnar nerve. So that will be paralyzed. You cannot choose opponent's policies because median nerve. First and second lumbricals, just now only we saw median nerve. Extensor carpi ulnaris. Extensor means radial. All introsei, of course, ulnar. So disability of the hand in ulnar nerve injury is because of paralysis of introsei and third and fourth lumbricals. Medial to lumbricals. Due to their involvement, claw hand, ulnar claw hand. Ulnar claw hand means partial claw hand develops. Complete claw hand you can expect in lower trunk injury, medial cord. partial clad hand isolated ulnar nerve injury. Introsiae. Skin over the dorsum of hand is innervated by. All of the above or only A and B? Sure. Okay, we will see. Oh, 3 colors are given, therefore 3 nerves are involved. The radial half of the dorsum by the radial nerve. Medial half of the dorsum, ulnar nerve territory. And the distal phalanx of lateral 3.5 digits, median nerve. There is considerable overlapping between the territories of radial nerve and ulnar nerve. In some textbooks you may see the ulnar nerve innervating 2/3 of the dorsal surface, medial 2/3 of dorsal surface, and in that case radial nerve will be innervating only the lateral 1/3 of the dorsal surface. In some textbooks it is just the other way around. Radial nerve innervating lateral 2/3 of the dorsal surface, only medial 1/3 of the dorsal surface is innervated by ulnar nerve. Considerable overlapping is there. Here everything is compromised, 50-50. This side 50, that side 50. So all of the above. Eppes paralysis. What is that hand called? Policeman Stips hand or Porter Stips hand. You keep your upper limb in that position and you will come to know which is applicable to the Eppes paralysis. Number 3. Keep your upper limb in Porter Stips hand position and you will come to know which of these findings will be true. This is the position of the upper limb in Eppes paralysis. The arm is adducted and rotated medially. Elbow extended, forearm pronated, wrist flexed. This 4 things. Arm by the side of the trunk, medially rotated. Elbow extended, forearm pronated, wrist flexed. Of the 4, only 1 was correct in that question. The other 3 were just the opposite. That is why they are wrong. That is this. Being a peripheral nerve injury, all reflexes will be absent. So here supinator jerk, biceps jerk will be absent. If a peripheral nerve is injured, all reflexes will be absent because there is no nerve to carry the impulses to the spinal cord. It is through the peripheral nerve impulses reach the spinal cord to have the reflex. If the nerve is damaged, then how can? Not possible. Therefore, reflexes will be absent. So, flexion at the wrist is the only correct finding. When the arm is in abduction, the head of the humerus is supported by is it rotator cuff muscle? Muscles of rotator cuff? Never, because they support the humerus everywhere except below. Coracohumeral ligament? Possible. Coracohumeral between the coracoid process and the upper end of the humerus. It is seen above. Not possible. So A and B also unlikely. There is only one muscle giving some support to the humerus from below when the arm is in abduction. That is this muscle. Because of this muscle, when the humerus is displaced, the nerve axillary gets caught between the two and damaged. Here, this person falls from the motorcycle. This is how he falls down. There is violent separation of neck from the shoulder at this point. That part is suddenly and violently stretched due to a fall like this. Neck is forcefully separated from the shoulder. This damages a part of the brachial plexus. Which is that part is our question. Any idea? Upper part of the brachial. Upper part is, there is no part called upper part. It could be upper trunk or middle trunk or lower trunk. Upper trunk. That means the C5 and C6 nerve roots joining to form the upper trunk. This can also happen when you pull the head of the baby at the time of labor before the rest of the body comes out. Forceful pull of infant's head, as you see in this picture. This area is unduly stretched. Forceps delivery, applying forces, sometimes can damage this part of the brachial plexus. See the position of the upper limb afterwards. What is this condition? What is this injury called? Okay, Erb's paralysis. His wrist is flexed. Why? Because of gravity, it is going down, that's all. No, you cannot keep the wrist in this flexed position. Due to gravity, it will fall down. Hand will go down. That doesn't mean that there is no flexion. That means upper trunk of brachial plexus. How many nerves meet at that point? This point is called Erb's point. 6 nerves. How? You see C5 and C6, 2 ventral rami, 2. And it divides into 2 divisions, anterior and posterior. In that way also 2, 2 plus 2, 4. 2 nerves arise directly from the upper trunk. Which are they? This nerve is the suprascapular nerve, a direct branch of brachial plexus. And another one which supplies a small muscle beneath the clavicle, nerve to subclavius. So in that way 2 plus 2 plus 2, 6 nerves meet at the Erb's point. Two roots of brachial plexus, 2 divisions of brachial plexus, 2 nerves of brachial plexus. There are 2 nerves which arise directly from the roots of brachial plexus. You can see one here, the other one. This nerve is quite long along the side of the thorax. That is why it is called so. It arises from the roots of C5, C6, C7, having a very long course in the thorax, hence called long thoracic nerve, supplying the serratus anterior. The other nerve supplies the rhomboides muscles, dorsal scapular, rhomboides major, minor, etc. So these are the two nerves arising directly from the roots. Two nerves directly from the trunk are the suprascapular and nerve to subclavius. So we have learned all about the brachial plexus indirectly without any direct effort from our side. By answering various questions on the brachial plexus, now we know how the brachial plexus is formed, what are the parts of the brachial plexus, what are their positions, what are the things that can damage the brachial plexus, what are the branches of brachial plexus from the cords of the brachial. Everything we have understood. So avulsion separation of the roots of spinal nerve C5 and C6 can do this. Examination pattern year-wise diluted. 1995 answer all questions. That is the usual thing in all question papers. Later it became answer any 5 questions. So first answer either A or B. Then 2015 you may expect at least read the question paper. 2020, thanks for coming to the examination hall. The breast is separated from the pectoralis major by 5. A only, either this end or the other end. Okay, we will see. This muscle is the pectoralis major. It is separated from the breast by its own fascia, deep fascia called pectoral fascia, and the retromammary space filled with loose areolar tissue. So pectoralis major is separated from the breast, or breast is separated from the pectoralis major by two things, retromammary space and the fascia covering the pectoralis major. In malignancy, cancer cells infiltrate into the retromammary space and also into the pectoral fascia. That restricts the mobility of the breast. In advanced stage of CA breast, there is restriction of mobility because of deep infiltration into the underlying tissue, retromammary space. The cervical fascia, we see the deep fascia of the cervical neck area has 3 layers: investing layer, pretracheal fascia and prevertebral fascia. These fascia and their facial planes are clinically very, very important surgically, because different types of abscess can occur in these gaps, like collar stud abscess, prevertebral abscess, that may extend into all adjacent areas through this facial continuity. That is the reason why we must know all about the 3 layers of the deep cervical fascia. Axillary sheath is an extension of one of the layers of the cervical fascia. Which is that, is our question. Number 3, 4, 2. That means you have chosen all 3. What is there? Shall I give you a clue? This fascia lies in front of the prevertebral muscles. covering the prevertebral muscles. Look at this. This is the axillary sheath. It is a covering of the brachial plexus and the axillary artery. It is a continuation of this fascia which lies in front of the prevertebral muscles. Prevertebral fascia. What is the clinical significance of knowing this? A person is having Cox spine affecting the cervical vertebrae, tubercular spine. Abscess, cold abscess is developed in the prevertebral area. This cold abscess can drag down along this facial continuity and can point on the lateral wall of axilla. Lateral wall of the axilla means arm. It can point the arm. It is a cold abscess. If you examine that area, axilla, adjacent part of the arm, you won't find any abnormality, but abscess is there. So cold abscess should not be trained towards gravity. You must be aware of such a thing. Cervical Cox spine abscess can drag down along this fascia and point on the lateral wall of the axilla. So prevertebral fascia actually forms the axillary sheath. Number 1. Okay, so inability to abduct and adduct fingers, definitely is a repetition, Melnar now. Now here, you are doing this cord test. This is for adduction. Which of the two introsi are we testing by this method? Palmar or dorsal? Palmar introsi. Palmar introsi for adduction. That is why it is that abbreviation is used, PAD, P for adduction, PAD, palmar introsi. And the other one is to test the abduction of the digits, means ask the person to set the two digits after applying pressure, resistance by your own digits. In spite of resistance, if the person is able to spread the digits, abduction is intact. This tests the integrity of which muscle? Dorsal introsi. So that is why the abbreviation DAB is used. D for abduction, P for adduction, like that. This we have already discussed. Yes, we all know. Okay, leave it. 51. True or false? Axillary vein lies outside the axillary sheath. What is your opinion? Is it true or false? True. Okay, we will see that to confirm. Here is the axillary sheath. You can see the vein lying outside. Normally, large veins in the periphery are seen outside any vascular sheath. This is because whenever there is increased venous return, there should be ample space for the vein to expand freely during increased venous return. If it is seen within a sheath, it cannot expand freely. That is why veins usually lie outside, or a dead space is provided very close to the vein for the vein to expand freely during increased venous return. For example, in the lower limb you can see there is a canal in the medial aspect of the femoral sheath. What is that canal called? Femoral canal. What structure lies immediately lateral to the femoral canal? The femoral vein. So there is a dead space provided medial to the femoral vein for the vein to expand freely during increased venous return. That is the purpose for which a canal is made in the medial compartment of femoral sheath. But accidentally, intestines may herniate into the femoral canal, can produce femoral hernia. So that is not the purpose for which this is designed, canal. This is the purpose, for the vein to expand freely during increased venous return. The median cubital vein, this is the vein commonly chosen for venipuncture in the upper limb. We all know. We usually choose this vein for withdrawal of blood and also giving intravenous fluid infusion. Does it connect the cephalic vein with the basilic vein is the question. Yes or no? Okay, we will see. Here is the cephalic vein runs along the lateral aspect of the limb. This is the basilic vein running along the medial aspect, and these two veins are connected by median cubital vein. There are two reasons for choosing this particular vein for venipuncture in the upper limb. Whenever you try to puncture a superficial vein in our body, it will play around. It will slip, difficult to penetrate, touch the tip of the needle. But this vein cannot slip like that. Why? Because it is fixed to the deep veins by several perforating veins. You can see a perforating vein piercing the biseptal aponeurosis, and that vein ends in the deep vein. Therefore, the vein, unlike other superficial veins in our body, cannot slip when you puncture this. Number two, you are seeing a structure here forming the floor of this area. What is this thing? Bicipital aponeurosis. It provides a stable platform on which the vein can easily be punctured. Two reasons. The bicipital aponeurosis gives a stable platform. Number two, it cannot slip. You can see the real photograph. This is the vein. While puncturing this vein, care must be taken not to damage two important structures here. If the needle goes a little deep, you may puncture one of these or both sometimes. What structure is this? Brachial artery may be punctured, and you will get frank arterial blood. And which nerve accompanies this artery medially? Median nerve. So if the median nerve is punctured, there will be sharp pain in that area, and that pain will be radiating to the lateral 3.5 digits. Sharp pain radiating to 3.5 digits when we puncture the median cubital vein, you see. This cubital fossa is bounded laterally by the brachioradialis and medially by the pronator teres. And the base of this cubital fossa is the imaginary line drawn between the two epicondyles. Apex is the meeting point of these two. Ulnar nerve is the only nerve that is not a content of this area, but radial nerve, median nerve are the real contents. You can see the brachial artery in this area dividing into ulnar and radial arteries. It is here the brachial artery terminates by dividing into radial and ulnar arteries. And this fossa is crossed superficially by the median cubital vein. The roof of this fossa is traversed by the median cubital vein. You can see that. And medial to the tendon of the biceps, we see two structures, brachial artery and the median nerve. Median nerve is the medial most structure here. We can feel the brachial artery, we can feel the pulsation of the brachial artery medial to the tendon of biceps. All you have to do is just push aside the tendon of the biceps by your finger, and you can feel the pulsation of the artery. It is more prominent than the radial artery. Just gently push aside the tendon of the biceps from the medial side. You can press that area, you can feel this artery. Yes, this is the site of palpation of brachial artery. That is why we keep the diaphragm of the stethoscope over this area to record the BP. And you can see the nerve here. Median nerve is superficial here, above the elbow. Again it is superficial near the wrist. But in this part it is under the cover of muscles. So therefore in this area the median nerve is not usually damaged. Three sites, one is here, another one is here, third one within the carpal tunnel. Brachioradialis is developmentally an extensor and functionally a flexor. Remember, being an extensor supplied by radial nerve. Correct. The metacarpophalangeal joints are in line with the proximal crease of digits. What is your opinion? Proximal crease of the digit means when the digit extends from the palm of the hand, you see immediately a crease, transverse crease. That is the proximal crease. Does this crease correspond with the MCP joint or not is the question. Yes or no? No. MCP joints correspond with the knuckles, the back. So what is the significance of knowing this? Whenever you apply cast to immobilize the joints of hand, care must be taken not to extend the cast to cover the knuckles. Cast should never cover the knuckles. Lower margin of the cast should be well above the knuckles. Only then free movements of the digits possible. You must, after applying the cast, you must see that the digits are movable or not. If the knuckles are covered by the cast, the digits cannot be moved. Then what will happen? You may think that the proximal crease is the site where the MCP joint is present. If you apply cast up to that area, the fingers cannot be moved, and you will advise the person to come after 1.5 months for the fracture or anything to heal. By the time the patient comes due to disused atrophy, all muscles cannot function and the person will develop shoulder hand syndrome. And it is difficult to correct. He has to do continuous physiotherapy at least for 2 years to correct this condition. So to avoid this, we must always apply cast above the knuckles to ensure free movements of digits. Sebaceous glands are absent in the palmar aspect of the hand. True or false? Only sweat glands are there in plenty, no sebaceous glands. Lower half of the deltoid is the usual site of intramuscular injection. Yes or no? True or false? Sure. Lower half. It is true. See, the deltoid muscle is a bulky muscle. The upper half of the muscle is in the shoulder, forming the prominence of the shoulder. What we see in the free upper limb is the lower half of the deltoid. So nobody gives injection in the shoulder. We give injection only in the arm. So that corresponds to the lower half of the deltoid. What we see there is the lower half, upper half is here, in the shoulder. Number 6, I think all of you know, this is the only muscle that does not rotate the humerus. Supinator is supplied by the deep branch of radial nerve, we have discussed already. True. Median nerve does not supply the muscles of arm. Does this nerve supply any muscle in the arm? No, this nerve is meant for supplying the muscles in the forearm mainly. Ulnar collateral arteries are the branches of ulnar artery. True or false? Ulnar collateral. False? False. Then what is it a branch of? Brachial artery. Let it be, we will see the diagram later. Bleeding from the wounds of the forearm can be stopped by compressing the brachial artery above the elbow, where the artery can be easily compressed against the lower end of the humerus, where we can palpate the artery, we can compress the artery. Can you stop the bleeding from a lacerated wound in the forearm? Yes or no? See, you are compressing the artery well above the elbow. In spite of that, you want to say no? Okay, we will see the diagram now. This is the brachial artery. What is the lower limit of axillary artery? That is the beginning of the brachial artery. Which muscle is shown in the picture? Teres major. Up to the lower part of the teres major axillary. Afterwards it is called a brachial. Which is the largest and the first branch of, first and the largest branch of brachial artery. That artery accompanies the radial nerve, profunda brachii. Then the artery gives us the two collateral arteries, ulnar side arteries, therefore ulnar collateral, superior ulnar, inferior ulnar collateral arteries. Then the artery terminates by dividing into ulnar artery and radial artery. They are the two terminal branches. Plus, the artery gives several unnamed muscular branches and also a nutrient artery to the humerus. Unnamed muscular branches and a nutrient artery to the humerus. In which way the profunda brachii and superior and inferior collateral arteries differ from other arteries in our body? Normally when you trace an artery, it becomes smaller and smaller till arteriole is formed. Then the arteriole becomes the capillary. From the capillaries venules begin, and from there large veins. That is the usual thing. But you see from the picture, what do? They end in what? The terminal branches of brachial artery. Profunda brachii ends in the radial artery, ulnar collateral arteries end in the ulnar arteries. Instead of becoming smaller and smaller, they simply end in this artery, forming an anastomosis around the elbow. This anastomosis, clinical importance is that even if you compress the brachial artery well above the elbow, the blood flow through the radial and ulnar artery cannot be stopped, because now in that case they get the blood from the collateral arteries, profunda brachii artery. Blood from the profunda brachii and collateral arteries will reach the radial and ulnar arteries. So you cannot minimize or stop the bleeding from a lacerated wound in the forearm, even if you compress the artery well above the elbow. If you compress the artery between the proximal and distal branches, bleeding cannot be stopped at all. So here comes the significance of the anastomosis around the elbow. So you ligate the artery somewhere here, no problem. You can ligate the brachial artery in the area where you record BP. You ligate it, nothing will happen. Then blood will follow this route and rest of the limb will be supplied. Here comes the significance of knowing this particular anastomosis. Okay, thus we complete all questions from upper limb. Right, okay. We will start questions from lower limb. What's time now? 3:30. Okay, we shall continue. Questions from lower limb. Let us start from the gluteal region. One statement about the gluteal region is incorrect. Which is that one? Number 2. Is gluteus maximus the chief extensor of the hip joint? Yes, that is why this muscle is called runner's muscle. But is this the key muscle of the gluteal region? No, it is the piriformis. Because once we identify the piriformis in the gluteal region, it is easy to identify all other structures around the piriformis. Some structures come out of the pelvis above the piriformis, others come out of the pelvis below the piriformis. All the neurovascular structures that we see in the gluteal region come from the pelvis. They come out through the greater sciatic foramen in relation to the piriformis. That is why this muscle is called the key muscle of the gluteal region. Which quadrant is usually chosen for intramuscular injection? Upper outer quadrant, because we can avoid injury to the sciatic nerve if we choose the upper outer quadrant. Sciatic nerve is related to the lower parts of the gluteal region. We will see the diagram now. This is the piriformis muscle, and we call this particular nerve superior gluteal because it runs above the piriformis. We call this one is inferior gluteal because it runs below the piriformis. This is the gluteus maximus, this is the medius, and this is the minimus muscle. And this particular nerve is called superior gluteal because it innervates, it lies above the piriformis. Which muscles are innervated by superior gluteal? Now we can say now. See, superior gluteal now innervates the gluteus medius and minimus. And this is inferior gluteal nerve. Which muscle is innervated by inferior gluteal nerve? Gluteus maximus. So gluteus maximus is supplied by inferior gluteal, whereas the two small muscles, medius and minimus, are supplied by superior gluteal nerve. So superior and inferior based on their position, not because of their what do you call their greatness or inferiority. The thickest nerve in our body is seen here, the sciatic nerve. And other nerves which come out of the pelvis below the piriformis include the posterior cutaneous nerve of thigh, the nerve to quadratus femoris, nerve to obturator internus, pudendal nerve. So one thing is clear from this picture. Muscles seen in the gluteal region are supplied by nerves other than sciatic. The most striking feature in the gluteal region is the sciatic nerve, no doubt. But it does not innervate any of these muscles. All these muscles are innervated by nerves other than sciatic. Superior gluteal, inferior gluteal, nerve to quadratus femoris, nerve to obturator internus, like that. The gamellae and everything is innervated by other nerves only. So this is the incorrect statement. This nerve, does this nerve supply any muscles anywhere in the limb? Yes, this is the nerve of the posterior compartment of thigh. It innervates all the muscles in the posterior compartment of thigh, not in the gluteal region. See, the thigh has three compartments, anterior, posterior and medial. What is the other name given to the medial compartment? Adductor compartment, because the muscles of this compartment produce adduction. Each compartment has its own nerve. Which is the nerve of the anterior compartment of thigh? Femoral nerve. It innervates all the muscles there. Nerve of the posterior compartment, sciatic. Nerve of the medial compartment, obturator nerve. Correct. So without overlapping, each compartment is innervated by its own nerve of that compartment. When this patient is asked to stand on his right foot, his left hip drops. His hip drops on the left side. It is due to damage to one of these nerves. Which is that nerve is the question. Superior gluteal. There are two superior gluteal nerves. Right or left? Right. Then anybody for inferior gluteal nerve? What is this test first of all called? Trendelenburg test. We will do that. Here the person stands on a right foot. The left foot is off the ground. In spite of standing on one foot, the person is able to maintain the gravity. The person does not fall down. You know why he does not fall down? Why he is able to maintain the center of gravity? You can see two muscles here. They are the gluteus medius and minimus. They pull the pelvis towards their side against gravity. You can see the pelvis is pulled towards their side against gravity, and that is how the balance of the body is maintained. The pelvis is tilted towards their side due to contraction of these two muscles. Suppose these muscles are paralyzed, let us see what happens. When these muscles are paralyzed and when the person tries to lift the other foot off the ground, the pelvis is no longer supported by the muscles. Due to gravity, it sinks onto the opposite side. It is tilted to the opposite side due to gravity. Now the person won't be able to stand on one foot. If at all he tries, he will fall down. This is what is called a positive Trendelenburg test. It indicates the integrity of superior gluteal nerve, because this is the nerve that supplies the two muscles, medius and minimus. So pelvis must be supported whenever we stand on one foot. Support in the sense it should be tilted towards the side of the stance limb. If it is tilted towards the side of the elevated limb, the person cannot maintain balance. This gives a peculiar gait in unilateral paralysis of these muscles and also bilateral paralysis. Unilateral dislocation or unilateral paralysis of these two muscles results in a peculiar gait. What is that gait called? Lurching gait. Lurching gait. Suppose muscles of both sides are paralyzed or bilateral dislocation of hip. This gives a duck-like gait, waddling gait. Waddling gait, up and down movement. Have you seen duck walking? That type of gait will be there. So which superior gluteal now you want to choose for this question? No doubt, now it is very clear. All of you, please. Okay, right superior gluteal now. See, as we have discussed before, the structures that we see in the gluteal region actually come out of the pelvis through the greater sciatic foramen. However, some of them re-enter the pelvis through lesser sciatic foramen. When they re-enter the pelvis, they actually pass through they are related to the dorsal aspect of the ischial spine. And these are the structures which go back to the pelvis by running on the dorsal aspect of the ischial spine. Which one you want to eliminate from the list? Pardon? There is a tip used for the three structures related to the dorsal aspect of the ischial spine. What is that? Pin structures, P-I-N. Let us expand. Here is the ischial spine. You can see some structures re-entering the pelvis through the lesser sciatic foramen. This is the greater sciatic foramen through which all structures come out, including the piriformis. And some re-enter the pelvis through the lesser sciatic foramen. They are 1. The pudendal nerve, the nerve of the perineum, internal pudendal artery, and this nerve, nerve to obturator internus, P-I-N. Pin structures. The nerve to quadratus femoris is here because quadratus femoris is a muscle on the gluteal region, therefore this nerve need not go there, need not reach the need not go back to the pelvis. It is there in the gluteal region, the muscle is there in the gluteal region, therefore the nerve supplies the quadratus femoris muscle by running behind the shoulder, behind the hip joint. So the right answer for this question is nerve to quadratus femoris. We have chosen the upper outer quadrant and we are giving injection. Does the needle pierce maximus, medius, minimus, or both medius and minimus? From the back. They are the new people. You might have heard all these things before. Others, newcomers from other institutions. Okay, we will see. This is the site of giving intramuscular injection. You can see the muscle here, gluteus maximus. Part of this muscle covers the upper outer quadrant, but we don't choose this area. We must choose the upper outer quadrant not covered by gluteus maximus. That means there is a gap, a shallow fossa is here between the iliac crest and the lateral border of this muscle. Since the entire gluteal region is not covered by gluteus maximus, this part is left free. It is not covered by maximus. That is why we see a shallow fossa over there. It is between the iliac crest and the outer border of the muscle, gluteus maximus. What will happen if we choose the upper outer quadrant which is covered by gluteus maximus? That means this area. We are not supposed to choose this area. If we choose this area, what will happen? Let us see. This is that area. What all junctures you are seeing over there, this is the share of the gluteus maximus, and if we choose this part of the gluteus maximus, we are likely to injure the superior gluteal nerve and vessels, and sometimes the common peroneal nerve, which comes out of the pelvis by piercing the piriformis in some individuals. Normally, the sciatic nerve divides in the lower part of the thigh, that is at the upper angle of the popliteal fossa, into two branches, which are the tibial and common peroneal. But in some individuals, the nerve divides within the pelvis. In such situations, what happens? The common peroneal nerve comes out of the pelvis by passing above the piriformis or by piercing the piriformis, as you see in this picture. Suppose a person you are giving injection is having that variation. Now the tip of the needle is likely to penetrate the common peroneal nerve also. That can end up in foot drop. So foot drop can occur if the common peroneal nerve is damaged. If superior gluteal nerve is damaged, it will give a positive Trendelenburg test. Medius and minimus will be paralyzed. So to avoid all these things, we must choose the upper outer quadrant not covered by gluteus maximus. The other branch is here. This is the tibial nerve. Normally these two nerves are not found in the gluteal region, but rarely they may be found if the sciatic nerve divides within the pelvis. We do not know whether the person is having that variation or not. In such individuals, if we do this, there is a chance for developing complications. So the near ear does not and should not pierce gluteus maximus. Whenever you come across a case of shortening of the lower limb, you must suspect two conditions. One is fracture neck of femur, the other is posterior dislocation of femur. These are the two conditions where the limb is shortened. How will you differentiate these two conditions? Whether it is due, before taking X-ray, whether it is due to dislocation of the femur or due to fracture of the neck of femur. Look at this photograph. Ask the person to lie down in supine position and you stand on the foot end of the patient and just observe the sole of the shortened limb. Here this limb is having the problem shortened. This limb is normal. You see the direction of the sole of the foot, it is turned laterally. It's not internally rotated, externally rotated. If you come across a case like this, in a case of shortening of the limb following trauma, it suggests what? Fracture neck of femur. On the other hand, if the sole of the foot is turned medially, the sole of the affected limb is turned medially, it indicates, okay, posterior dislocation of the hip. What is given in the question? Limb is shortened, internally rotated. That is suggestive of posterior dislocation. Very simple. Anatomical explanation is there, but those things are not necessary. I am not going into the details. Why the limb is internally rotated in dislocation? Why the limb is externally rotated in fracture neck of femur? Beautiful diagrams are there in anatomy textbooks. You are moving your lower limb backwards. After some distance, you cannot move it further back. This ligament does not allow it to move further back. Extension is prevented. Hyperextension is prevented. Which is that ligament is our question. You are going on moving the limb backward. That we use it for running. After certain distance, you cannot do that. You cannot move it further back. It is limited by this ligament. Which is that ligament? Yes, no idea? Number 1, iliofemoral. Look at this ligament. This has the shape of an inverted Y, letter Y. Therefore, it is also known as Y ligament of Bigelow. When you extend the thigh backwards, when you move the thigh backwards, this ligament prevents too much extension of the limb. What is this spine? What is this spine? Going to be labeled anterior superior iliac spine. This spine gives attachment to one muscle and one ligament. Can you name the muscle and the ligament? Sartorius and inguinal ligament. Perfect. Sartorius and inguinal ligament. What about this one? What is this name of this spine? Anterior inferior iliac spine. It also gives attachment to one muscle and one ligament. Ligament is already labeled, which is the muscle. Ligament already labeled, that is Y ligament, which is the muscle. It is one of the muscles of quadriceps femoris. I have given you the clue. Quadriceps femoris means 4 muscles. Rectus femoris and 3 vasti. Vastus medialis, vastus intermedius and vastus lateralis. Of the 4, which one? Exactly, rectus femoris, right head. Unlike the vasti, this muscle can act both at the hip and at the knee joint. What is the main primary action of quadriceps femoris? Extension of the knee. When we gently tap the ligamentum patellae, knee is extended due to contraction of quadriceps femoris. That tests the integrity of which nerve? Femoral nerve. Which segments of the spinal cord? A positive knee jerk tests the integrity of which spinal segments? L2, L3, L4. What is the root value of the femoral nerve? Same thing, L2, L3, L4. The root value of the femoral nerve is L2, L3, L4, and it is this nerve that supplies all 4 bellies of the quadriceps femoris, and when we gently tap the ligamentum patellae with our knee hammer, knee is extended due to contraction of quadriceps femoris. That indicates the integrity of femoral nerve. In other words, the 3 segments of the spinal cord, L2, L3, L4. Okay, we gently stroke the medial aspect of the thigh, upper thigh. The testis is, in males, the testis is pulled upwards. What is this jerk called? Cremastic reflex. Which segments of the spinal cord are tested by this reflex? L1 and L2. Which nerve for L1? That nerve is the upper limb of the reflex. Ilioinguinal nerve. L2 nerve, genitofemoral nerve. So, a positive cremastic reflex tests the integrity of ilioinguinal nerve coming from L1 and genitofemoral nerve coming from L2. A positive angle jerk tests the integrity of S1 and S2. Okay, perfect. Because in lower limb, even the jerks, knee jerks and also the dermatome of the lower limb, these things are quite important to know the involvement of the exact spinal segments in a case of spinal cord injury or in a case of IVDP, intravertebral disc prolapse. We can even before taking X-ray or CT scan or anything, we can clinically assess by the neurological deficits where exactly the problem has occurred. You are seeing a bursa here. Can you name this bursa? This bursa prevents friction between the muscle which runs over it and the capsule of the knee joint. And that muscle is inserted into the lesser trochanter of the femur. It is the strongest flexor of the hip joint. I have given you all clue necessary for identifying that muscle. This muscle is inserted into the lesser trochanter and it is the powerful flexor of the hip joint. It has 2 parts. One part comes from the lumbar region, other part comes from the iliac region, and the 2 bellies fuse to form a common muscle, and a tendon is formed that tendon is inserted into the lesser trochanter. Which muscle are we talking about? Iliopsoas, psoas major, and therefore this bursa is called psoas bursa. Whenever this muscle is inflamed in pelvic abscess or retrocecal appendicitis, irritation of this muscle, what will be the position of the hip joint in that individual? Will the hip be flexed in the flexed position or in the extended position? Flexed position. Why? That also clearly, if a person, is finding it difficult to extend the hip due to pain, you must suspect some problem in the pelvis. Psoas abscess or any inflammation of the muscle, retrosacral appendicitis or anything. What is the anatomical reason behind this? See, whenever a muscle is inflamed, it is not the contraction of the muscle that produces pain. It is the stretching of the muscle that produces pain. What is the action of this muscle? Flexion of the hip. If the muscle is stretched, that means that can occur when in extension. Whenever the muscle is stretched due to contraction of extensors, pain is felt. To avoid pain, the person keeps the muscle in contraction. That, in other words, keeps the hip in flexed position. That is why in such situations we see the patients with hip flexed. Extension produces pain because extension means stretching of the muscle, so pain. Similarly, the calf muscles inflamed, deep muscles of the calf. Is it dorsiflexion that produces pain or plantar flexion that will produce pain? Dorsiflexion, because calf muscles are there for plantar flexion. So if you dorsiflex your foot, the tenderness can be elicited or pain will be felt. Iliofemoral ligament is one of the strongest ligaments in our body. Which is the longest muscle in our body? Which is the longest bone? Which is the strongest tendon? Yes, sternocalcaneus, Achilles tendon. Which is the longest superficial vein in our body? Saphenous means there are two. You must specify. Great saphenous vein. Okay. Short saphenous vein goes only up to the popliteal area. It ends in the popliteal vein, so it is not that long. Great saphenous vein. Similarly, a very long cutaneous nerve, longest cutaneous nerve in our body. Saphenous nerve. See, all these things are there in the lower limb. All long and strong structures are there in the lower limb. Which is the smallest bone in our body? That is, smallest muscle, skeletal muscle, stapedius, in the ear, middle ear, ear ossicle, stapes, and the small muscle supplied by the facial nerve, stapedius. Posterior dislocation of the hip, you must always suspect injury to this nerve. Posterior dislocation, you must suspect injury to this nerve. Which nerve? Sciatic. Sciatic nerve. Look at this picture. Sciatic nerve runs immediately behind the hip joint. Whenever the femur is displaced backwards, this nerve is unduly stretched, foot drop can occur. Foot drop can occur. Why foot drop? Because common peroneal nerve is a branch of sciatic nerve. So, it is equivalent to injury to the common peroneal nerve. Foot drop will occur. This is the problem. Whenever there is disease in the hip, pain will be felt in the knee and vice versa. Disease of the knee can produce pain in the hip. Why? Pain is referred from one joint to other. Diseases of the hip produce pain in the knee, and diseases of the knee often produce pain in the hip. Number 1, obturator. Number 5, perfect. Because both these joints are innervated by both the obturator nerve and femoral nerve. You know, they have the same root value. L2, L3, L4. Why? Because they come from the same stuff, lumbar plexus. Root value of the lumbar plexus, L2, L3, L4. One is a branch of ventral division, other is a branch of dorsal division. Have the same root value coming from the lumbar plexus, which is arising from the ventral division and which is arising from the dorsal division. Ventral femoral nerve, dorsal obturator, ventral obturator, femoral dorsal. If either of these could be true, no doubt. See, whenever you come across doubts like this, we must always find out a tip for this to avoid that confusion recurring. You have excess money, you want to deposit that money in a bank. What kind of deposit will you make to get maximum interest? Savings bank account interest or fixed deposit? Fixed deposit. Fixed deposit means FD. I think there is a clue here. F for femoral nerve, D from dorsal division. FD. Look at this. Okay, that picture will come after some time. There is a picture to show you the two branches coming from the lumbar plexus, one from the ventral division, other from the dorsal division. That I will show you later. Location of the saphenous opening is clinically significant. If you want to test the nature of varicose vein, you must occlude this saphenous opening and see whether the blood fills from below quickly or not, to know whether the perforators are damaged or whether the valves of the main vein is damaged. So what is that? Which one you want to choose for this? Number 4. 4. Here is the pubic tubercle, an important landmark in the pubic region, which gives attachment to the medial end of pubic, inguinal ligament. First, feel the pubic tubercle, invariably felt in all individuals, and 3 to 4 centimeters below and lateral to this is the saphenous opening, pierced by the great saphenous vein. Great saphenous vein pierces the cribriform fascia and ends in the femoral vein. Mid-inguinal point and midpoint of the inguinal ligament, are they one and the same? No. Midpoint of the inguinal ligament means the point midway between the two attachments of the inguinal ligament, that is somewhere here. Laterally anterior superior iliac spine, medially pubic tubercle, you take a point midway between these two. That will be the midpoint of that ligament. But mid-inguinal point is something different. What is that? Laterally you can use the same point, that is anterior superior iliac spine. But medially, instead of tubercle, we must use the pubic body or pubic symphysis. Take a point midway between these two. Pubic symphysis medially and this anterior superior iliac spine laterally. What is the purpose behind choosing such a point? It is here the external iliac artery becomes the femoral artery. It is the beginning point of femoral artery. Femoral artery begins at the mid-inguinal point. So if you want to feel the pulsation of the femoral artery, you must keep your digit over the mid-inguinal point. And in one cardiac disease, if you keep the diaphragm of your stethoscope, you will hear pistol shot sound, aortic incompetence, aortic regurgitation. So for that purpose also, you should know where to locate the mid-inguinal point. 4 muscles form the floor of the femoral triangle, and all 4 are given here. But one muscle is not correct. Which is that muscle? 1. Adductor brevis. Then if not adductor brevis, which muscle then? Adductor longus. Adductor longus forms the medial boundary of the femoral triangle. You want to include that muscle for the floor also. Lateral boundary is the sartorius. Medial boundary of the triangle is the adductor longus. So that means you want to include this muscle both for the medial boundary and floor. Look at this femoral triangle. This is the femoral triangle. This much. This is a triangle bounded laterally by the medial border of sartorius and medially by the again medial border of adductor longus. We have to take the medial border of adductor longus for the medial boundary of this triangle. Therefore, adductor longus not only forms the medial boundary but also the floor, the first muscle of the floor. Then comes the pecuneus, then comes the psoas major, and finally the iliacus, and these two things fuse to form the iliopsoas. These are the 4 muscles forming the floor of the triangle. You can see the quadriceps femoris. Rectus femoris is one here. This is the vastus medialis, this is the vastus lateralis, and vastus intermedius will be seen if you cut and reflect the rectus femoris, deep to which you will see the intermedius. All 3 vasti begin from the femur. They take origin from the femur and are inserted into the patella. But rectus femoris is not like that. It comes from the hip bone to be attached to the patella. That is the reason why the rectus femoris can act at both joints. In the hip it produces flexion and in the knee it produces extension. Because it crosses 2 joints, just like our biceps in the upper limb. In 1990, TV was like this, persons were very lean. Now this has become very lean and persons have become fat. Number 3. Housemaid's knee, clergyman's knee. Both are bursitis. There are several bursae surrounding the knee joint. This one is due to which of these? Number 3. Sure. See, in this case, it is the prepatellar bursa. Prepatellar means the bursa that lies in front of the patella, that comes in contact with the ground, undergoes constant friction and inflammation. But in clergyman's knee, the flexion of the knee joint is maximum 90 degree. It won't go beyond that for prayer and everything. It is the infrapatellar bursa somewhere here. Infrapatellar bursa will be seen below the patella, and this is the bursa that is actually involved in clergyman's knee. Most of the lower limb is drained by the superficial inguinal lymph nodes. Not only that, the lymph nodes, superficial inguinal lymph nodes drain the entire perineum, including the anterior abdominal wall below the level of umbilicus. But there is a part of external genitalia which is not drained by superficial inguinal lymph nodes. Most of the external genitalia and the entire perineum are drained by superficial inguinal lymph nodes. That is why in all sexually transmitted diseases, the superficial inguinal lymph nodes are enlarged. Primary chancre, lymphogranuloma venereum, granuloma inguinale, in all conditions, the bubo that we see in LGV, definitely superficial inguinal lymph node. But this part of the external genitalia is drained into the deep inguinal lymph node. Which is that part is our question. Number 3. Sure. You can see normally, this is the femoral sheath, and the medial compartment of the femoral sheath is the femoral canal. It is filled with loose areolar tissue and 1 or 2 deep inguinal lymph nodes. This deep inguinal lymph node is known as lymph node of Rosenmuller or Cloquet. And this one drains the glans penis in males or the glans clitoris in females. This diagram also shows the 3 compartments of the femoral sheath and the structures occupying each. The middle compartment is occupied by the femoral vein and the lateral compartment is occupied by the femoral artery. What about the femoral now? Is it a content of the femoral sheath? No, it lies outside. Which is the lateralmost structure in the femoral triangle? If you come across a question like this, and these are the 4 choices given. Femoral nerve, femoral artery, femoral vein, femoral canal. Which one will you choose? Femoral nerve is the lateralmost structure. Which is the medialmost structure in the femoral triangle? The choices given are lymphatic vessels or inguinal lymph nodes, femoral canal, femoral vein, femoral artery. Lymphatic vessels. Lymphatic vessels are the inguinal, the lymphatic vessels which drain into the inguinal lymph nodes are the medialmost structures. The mouth of the femoral canal, we all know, is called the femoral ring. It is this ring that is widened to relieve the obstruction in femoral hernia. For that purpose, a structure forming one of these boundaries is divided to widen this opening to relieve the obstruction. Irreducible femoral hernia or strangulated femoral hernia. Number 3, lacunar ligament. Look at the femoral sheath here. This is the femoral canal and the mouth of the canal is called the femoral ring. It is bounded anteriorly by this ligament. Which ligament it is? Correct. Posteriorly by the pelvic brim. This is the pelvic brim. This part of the pelvic brim is given a special name because it has a prominence over there. That is why. Iliopectineal eminence or pecten pubis. That forms the posterior boundary. So posterior boundary of this canal is bony. The lateral boundary is the septum separating the femoral vein from the canal. What about medial boundary? A semilunar ligament. That is why it is called so. Moon-like lacunar ligament. Half moon-like. It is this ligament that is divided to widen the femoral ring while relieving the obstruction. When the surgeons will divide this ligament, make an incision in this ligament, they often take extra care not to damage one blood vessel over there, seen in some individuals. What artery? Abnormal obturator artery or aberrant obturator artery may cross this area from the pelvis. It may be crossing the lacunar ligament like this. If they are not aware of such thing, this vessel is likely to be damaged. It can produce profuse bleeding in that area. So care must be taken not to damage this vessel if it is present. Look for the vessel before, then avoid damaging it. A stab wound. At what time are we going to have tea break? 4:15 now. Where are our organizers? We will confirm whether tea is ready or not afterwards, otherwise it will be time consuming. Dasan? Anybody from the back, can you call that person, Dasan or somebody? Nobody is there. Okay, we shall wait for 5 to 10 minutes. Let those people come. Now nobody is. That's it. Tea break uda alle. Parayamayirunallo. Yes, now we can have 5 to 10 minutes break. Come. Coffee Madi. It's not a substance.
നാല് മണിയായപ്പോഴത്തേനും നിങ്ങൾ ആരെങ്കിലും വരുമോ എന്നൊക്കെ നോക്കി. കാരണം തീ റെഡിയാകുന്നതിന് മുമ്പ് വിട്ട് കഴിഞ്ഞാൽ സമയം പോകും. അതുകൊണ്ട് നിങ്ങൾ എപ്പോഴും ഒന്ന് ഈ ആയി കഴിഞ്ഞാൽ ഒന്ന് കാണിച്ചാൽ മതി. തല കാണിച്ചിട്ട് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഞാൻ ഉണ്ടാവും. അപ്പൊ അതിനനുസരിച്ച് ഞാൻ നിർത്തും.
So we shall continue. Question number 14. A stab wound near the apex of the femoral triangle can injure which of these? Numbers 4, 5, A and B. Not all of the above. Okay, we shall see. Look at this picture. This is the site of stab injury where we see the femoral vessels. The femoral artery and vein are related to the apex of the triangle. But where is our femoral nerve? It is confined to the base of the triangle because the femoral nerve is a very short nerve. It enters the triangle and soon divides into a number of branches like a fountain. It does not extend down to the level of the apex. It is confined to the base of the triangle. However, a branch of the femoral nerve descends to the level of the apex of the femoral triangle. That nerve we are going to see in the next picture. This is that nerve. This is the femoral nerve. It divides into number of branches to supply all the muscles in this compartment. And you can also see a nerve here. It runs like this, very in close relation with the femoral vessels, passes through a canal here, adductor canal. It goes further down and you can trace this nerve down to the medial border of the foot. Which nerve is it? Exactly. This is the saphenous nerve, the longest cutaneous nerve. It starts from here, ends along the medial border of the foot. So up to that level, you can see this nerve. So what you have chosen is perfectly odd. This is the diagram that I wanted to show you before. This is to show the lumbar plexus. Lumbar plexus, two nerves arise from the lumbar plexus. This is the nerve coming from the ventral division. This is the nerve coming from the dorsal division. You can see this nerve. This is the shortest nerve here, soon divides into branches. That is our femoral nerve from the dorsal division. And this is the nerve coming from the ventral division. It passes through the obturator canal, through the obturator nerve. Also you can see this muscle, psoas major, and also it is joined by the iliacus from the iliac fossa to form a common tendon which is inserted into the lesser trochanter. You can appreciate three nerves in relation to the psoas major. The lateral border of the major is related to the femoral nerve. You can see that. Medial border is related to the obturator nerve. Also you can see a nerve piercing the psoas major to descent, which is that nerve. Exactly, genitofemoral nerve. So these things are important because whenever this muscle is irritated, inflamed, these nerves are irritated and pain can be referred to the areas of distribution. Genitofemoral nerve pierces the muscle. Genitofemoral nerve. So what you have chosen is perfectly correct. A and B among the 5 choices given here, A and B quite correct. Adductor canal. What are the other names given to this canal? Hunter's canal and also subsartorial canal. Why it is called adductor canal? Because it is seen in the adductor compartment of thigh. That means medial compartment of thigh. Where exactly in the medial compartment? Middle 1/3 of the thigh. It occupies the middle 1/3 of the thigh of the adductor compartment. Therefore called adductor canal. This canal lies deep to the sartorius muscle. Therefore called subsartorial canal. Also known as Hunterian canal because it was John Hunter who first discovered this canal to treat one clinical condition. That we will see later. You see this, which of these actually passes through this adductor canal? That is our question. Which of these passes through the adductor canal? Oh, if I show this thing, others cannot see from there. Okay, let us use them. Which one you want to choose for this question? Femoral artery, profunda femoris, medial circumflex femoral or lateral circumflex femoral? Nobody knows. Such a big canal in the adductor compartment. Clinically also important. We will see this canal. Look at this. What type of canal is this? It is a fibromuscular canal. You see the roof of the canal is fibrous tissue. Floor of the canal is formed by two muscles. One muscle in the upper half, this is adductor longus. One muscle in the lower half, that is adductor magnus. So floor of the canal is formed by two muscles, adductor longus and magnus. Roof is a fibrous septum. It also has an anteromedial wall. You can see the anteromedial wall here. Which muscle forms the anteromedial wall? You can see that. It's not anteromedial, anterolateral wall. Anterolateral wall. Which muscle it is? Vastus medialis. Correct. Now the structures passing through this canal include first the femoral artery. You must note that. Femoral artery and femoral vein pass through this canal. That is the most important thing. Then you can see the femoral vein. Then you can see saphenous nerve. Also you can see the nerve to vastus medialis. These are the four structures passing through this canal. It is triangular in section. We will see them again in the cross section. You can see the two muscles forming the floor of the canal. This is the adductor longus and this muscle is the adductor magnus, and you see a large opening here in the adductor magnus. The femoral artery, leaving the apex of the triangle, passes through this canal and leaves this canal by passing through this opening in the adductor magnus. Then it becomes the popliteal artery. So femoral artery is a very long artery right from the base of the triangle down to the level of the adductor opening in the adductor magnus. Also you can see in the muscle adductor longus and brevis with several perforations. Four such perforations are found in these muscles. They transmit the perforating branches of profunda femoris artery. Look at this picture. This muscle is the sartorius. Here is the pubic region. Knee is here. Inguinal area is here. You see the triangular section. It is triangular in cross section, the canal. The structures passing through, as we have seen before, one, saphenous nerve, femoral artery, femoral vein, and nerve to vastus medialis. These are the four things passing through the canal. Injury to the nerve of vastus medialis can result in paralysis of vastus medialis. That can result in one clinical condition. What is that? If the vastus medialis is paralyzed, what will happen to the patella? It will result in lateral dislocation of patella. Lateral dislocation of the patella is due to involvement of vastus medialis. Because of the unopposed contraction of vastus lateralis, the patella will be moved laterally. John Hunter saw a patient with a large popliteal aneurysm. He saw a very large aneurysm in the popliteal artery. Anytime that aneurysm can rupture, that was the situation when he observed that aneurysm in that patient. He wanted to reduce the blood flow through the popliteal artery to prevent the rupture of the aneurysm. So he traced this artery and found the adductor canal in the medial compartment of thigh. He could cut open that canal and see the femoral artery in the adductor canal. he successfully ligated the femoral artery to reduce the blood flow through the popliteal artery. Thereafter, this canal is known by his name, Hunter's Canal. It was he who first discovered this canal in order to ligate the femoral artery to decrease the blood flow through the popliteal artery in a case of popliteal aneurysm. John Hunter is also known for one more thing clinically. What is that? The primary chancre of syphilis is also known as Hunterian chancre. It was John Hunter who first described the development of primary chancre in syphilis. How? By introducing the Treponema pallidum spirochete into his own genitals and saw the development of primary chancre in an era where the antibiotic was not discovered. Death is inevitable. He might have died of tabes dorsalis. So femoral artery is the right answer for this question. About the hamstring muscles, find out the incorrect statement. Which of these is incorrect about the hamstring muscles? Muscles on the back of the thigh are collectively called hamstring muscles. How many muscles do we see on the back of thigh? Only 3. The semitendinosus, semimembranosus on the medial aspect, biceps femoris on the lateral aspect. And a part of adductor magnus also protrudes into the posterior compartment. Because adductor magnus is a very large muscle. That is why it is called magnus. Magnus means magnanimous, quite large. It is not only found in the adductor compartment but also in the hamstring compartment of thigh. Being in the hamstring compartment, it is also supplied by the sciatic nerve. One statement about the muscles here is incorrect. Which is that one? Look at this. This is the back of thigh. You can see the gluteus maximus very prominent. This is the iliac crest, and you are seeing a shallow depression here. What is the significance of knowing this depression? This is the site of gluteal injection. This is the site of gluteal injection. And this muscle has a very long tendon, that is why it is called the tendinosus. And it rests on a very bulky muscle, the membranosus, deep. And this side we see the two heads of the biceps fused to form a tendon which is inserted into the head of the fibula. And these muscles form the upper boundaries of the popliteal fossa. Upper medial boundary by these two muscles, lateral boundary by the biceps tendon. And you can see the popliteal vessels here, and also the femoral nerve and the common peroneal nerve. This is the this is tibial nerve, and this is the common peroneal nerve. Okay, these muscles arise from which part of the hip bone? Ischium, not from the ilium. So they are seen on the back. Therefore, they are actually extensors of the hip. They assist the gluteus maximus in extending the hip. Where are they inserted into? They cross the knee joint and are inserted into the bones of the leg. These two muscles are inserted into the medial bone of the leg, that is tibia. This muscle is inserted into the head of the fibula. So they cross the knee, therefore they can act at the knee also. What action do they have at the knee joint? Flexion, correct. Flexion of knee and the extension of the hip are the functions of actions of these muscles. Now let us go back. They are inserted into the bones of the leg, perfect. They are all supplied by the sciatic nerve, that also okay. They produce extension at the hip and flexion at the knee because muscles cross both. But they do not take origin from the ilium, rather they take origin from ischium. Congenital talipes equinovarus. Which of these is not a position of the foot? Number 4. Look at this photograph. the foot is adducted, inverted and plantar flexed. Plantar flexion means, assume that this is my foot. If I elevate my foot, what is this called? Dorsiflexion. If I depress my foot, plantar flexion. I turn the sole of the foot medially towards the midline of my body. This is inversion. Is it inversion or reversion? Inversion. Turning the sole of the foot laterally, eversion. So dorsiflexion, plantar flexion, inversion, eversion. Now look at this. This is plantar flexed and inverted. And a little bit adducted means a little bit an exaggerated inversion is called adduction. That's all. But is it everted or dorsiflexed? No. These things are not there. So lateral rotation, that is eversion. Lateral rotation is not there. Adduction, inversion, plantar flexion are okay. Medial meniscus is more prone to injury because all four statements given here are correct, but only one is quite specific. What is a common form of tear of medial meniscus called bucket handle tear? It is an anterior-posterior tear. Why this tear often occurs in the medial meniscus? Why not in the lateral meniscus? Now answer, right answer for this question. Show your digits, number 4. I want to go with number 4. Let us see. Look at this. This is the femur, this is the tibia, medial condyles. Here is the medial meniscus, and you are seeing a flat ligament on the medial aspect of the knee. This flat ligament is called medial collateral ligament, also known as tibial collateral ligament. This tibial collateral ligament has two parts, a superficial part and a deep part. See the diagram again. The deep part is attached to the medial meniscus. So what happens during sudden twisting of knee joint, as we commonly seen in football players, the medial meniscus cannot slip because it is fixed by the deep part of the tibial collateral ligament. Therefore, it gets caught between the two bones and crushed. But lateral meniscus can escape. It can slip because it is not fixed by any ligament. That is why medial meniscal tear is more common. A typical anterior-posterior tear resembling the handle of the bucket occurs as you see in this picture. You see, this is the anterior-posterior tear of the medial meniscus. This is the handle of the bucket, and this is the bucket itself. Since it resembles the handle of the bucket, this anterior-posterior tear is known as bucket handle tear. You see the medial lateral collateral ligament. This ligament is called lateral collateral ligament, also known as fibular collateral ligament. This is a very strong ligament. It is a cylindrical cord and usually not damaged, not involved in injury in in moderate injuries of knee joint. Severe injury, it may also be damaged, but in usual moderate injuries, this ligament is not usually involved. So the reason for frequent damage to the medial meniscus is this. Locking and unlocking are the two important extra movements occurring in the knee joint. See, the knee joint is not a typical hinge joint. You should know. Knee joint is not typical hinge joint, just like our elbow or ankle. They are all more. Elbow is typically a hinge joint, and 95% ankle joint also hinge. But knee joint is not a hinge joint because in addition to flexion and extension, rotatory movements of the bone forming the knee joint also occur. Tibia can rotate, femur also can rotate. Femur can rotate on the tibia or tibia can rotate on the femur. Since rotatory movements also occur, knee joint is a complex joint, often known as condyloid joint, because two condyles of the femur articulate with the two condyles of the tibia. Therefore, condyloid joint or bicondyloid joint, in whichever way you can explain. When we stand like this, our body is supported. The knee is in extended position. We are able to stand without losing the balance. What actually happens at this time? Simple extension of the knee is not sufficient to support the body weight. After full extension, what happens? The thigh rotates medially. ഇപ്പോൾ ഞാൻ അങ്ങോട്ട് പോവാം. അപ്പോൾ അവിടെ പ്രോബ്ലം വരുന്നുണ്ടല്ലേ? ഇവിടെ ബ്ലോക്ക്, അവിടെ മുഖം കാണുന്നില്ല, എന്തൊക്കെയാണ്. അപ്പൊ ഞാൻ ഇരിക്കുന്ന സ്ഥലത്തേ പറ്റൂ. അപ്പൊ അങ്ങോട്ടും ഇങ്ങോട്ടും സ്ട്രെച്ച് ചെയ്യാനൊന്നും പറ്റില്ല. So after full extension, the thigh, femur rotates medially, because the medial condyle of the femur and the medial condyle of the tibia are quite larger. Only when the thigh is rotated medially, the large medial condyle of the femur completely occupies the large medial meniscus on the medial condyle of the tibia. This movement that occurs after full extension of the knee is called locking. Once this medial rotatory movement has occurred, the entire limb, lower limb, becomes a rigid pillar capable of supporting our body. Now it becomes one unit. The entire lower limb, right from the hip down to the big toe, becomes one unit, so that it can support the body easily. This you can test. A person is standing like this. Somebody from behind gives a gentle push into the popliteal fossa of both knee. What will happen? The person will immediately fall down. Why? Even now the knee is extended, but the person is not able to support the body. If the person falls down, what happens when we give a gentle push into the popliteal fossa? A muscle is activated. It is a small muscle seen in that area. What is the muscle, you know? Popliteus. It rotates the femur laterally and thereby unlocking the knee. Once the knee is unlocked, it cannot support the body. Therefore, the person falls down. So, locking of the knee is essential for locomotion, standing and locomotion. What is it actually? Simple medial rotation of the femur on the tibia when we stand after full extension. A locked knee cannot be flexed. You know that? A locked knee cannot be flexed. It should be unlocked first. Only then flexion is possible. Only then locomotion can progress. What should be done to unlock the knee? The femur should rotate laterally. If the femur rotates laterally, the joint is unlocked, then you can flex the knee. All these things occur automatically. That is why we are often not aware of this. We simply think that, okay, knee is extended, knee is flexed. That much only we know. We do not know whether the femur is rotating medially or laterally. We are not aware of it. But this is happening automatically. That is why we are able to support our body. Otherwise, body weight cannot be supported. We will fall down. So these two movements are collectively called screw home movement of knee. Our screwdriver, that screw. Home, going home, that home. Screw home movement of knee. Now it is very clear. You can find out the right answer for this question. Unlocking of the knee occurs in initial phase of flexion. Suppose you want to choose extreme extension. What modification will you make in the question? Locking. Locking of the knee is carried out by the quadriceps femoris. Quadriceps femoris is responsible for locking the knee, especially the vastus medialis. Unlocking is carried out by the popliteus muscle. Locking and unlocking are nothing but the rotation of the femur on the tibia. That's all. An injury, a penetrating injury, well above the patella also can infect the knee through a bursa, which is often regarded as a part of the knee joint because it is always continuous with the knee joint. Therefore, infection can extend into the knee joint even if a penetrating injury occurs well above the patella. Well, which is that bursa? Look at this. This is the situation. There is a very large bursa in front and extending above the patella. This bursa is known as suprapatellar bursa because it lies above the patella, extends above the patella. It is always continuous with the synovial cavity of the knee joint. That is why infection of this bursa is equivalent to infection of knee joint. Want to see the real job bursa? This is that. Suprapatellar bursitis can result in infection of knee. If the physician is able to pull the tibia forward easily, no resistance is there, this indicates damage to one of these ligaments. This is what is called positive Draver's test. Which ligament is actually damaged? For the physician to pull the tibia forward. Want to go with anterior cruciate? See, knee joint is peculiar in that it is not only supported by several external ligaments but also by two internal ligaments which lie within the joint, intracapsular. And these two ligaments cross themselves along their course. That is why they are called cruciate ligaments. And these ligaments are named anterior and posterior based on their attachment to the tibia, not to the femur. Remember. Look at this picture. This is the anterior cruciate ligament because it extends from the anterior end of the tibia. This is the posterior cruciate ligament because it extends from the posterior end of the tibia. Posterior end of the tibia. They form a cross. And these two ligaments are responsible for the anterior-posterior stability of the knee. The femur cannot go back or forward because of these two ligaments. Similarly, the tibia is fixed. It cannot move forward, it cannot move backward because the two ligaments will not allow. So, anterior-posterior stability of the bones of the knee joint is maintained by the two cruciate ligaments. In this case, the physician is able to pull the tibia forward. He is able to pull the tibia forward in relation to the femur. Too much pulling, too much forward movement occurs in the tibia when the physician pulls the tibia. It indicates damage to, you said, anterior cruciate ligament. Okay, perfect. Look at this. If anterior cruciate ligament is damaged, the tibia can be pulled forward. There is no resistance. Now, backward displacement of the tibia is prevented by posterior cruciate ligament. Anterior displacement of the tibia is prevented by anterior cruciate ligament, because you see the condyles of the femur are quite large and rounded, but the upper end of the articulating surface of the tibia is quite flat. Such a large bone with bearing the body weight is actually kept on a flattened surface. Medial menisci and lateral menisci are there, they deepen the cavity to some extent, but it is actually a flat surface. How can such a long bone with supporting the body can be kept in that place? Only because of the two ligaments and other ligaments surrounding the joint. If these ligaments are damaged, it cannot be kept in that place. So displacement will occur easily. And you see what has happened in this situation. The thigh is rotated laterally, leg is rotated medially, producing a sudden twist in the knee joint. Whenever such a twisting injury occurs in the knee, three structures are normally damaged. Which are the three structures? What is that clinical triad called? Exactly. You can see that here is the tear of anterior cruciate ligament, plus you will see two more. Tear of tibial collateral ligament and bucket handle tear of medial meniscus. And these three signs are known as the unhappy triad of Wodonek. Thigh is rotated in one direction, leg is rotated in the opposite direction. How? A sudden twist will occur. Just like squeezing a wet towel. We do the same thing for squeezing a wet towel, to squeeze water from a wet towel. If it occurs so suddenly, these three ligaments are damaged. But you see the fibular collateral ligament, it's not that damaged, because it is a very strong ligament, a cylindrical rod, not normally injured in mild and moderate injuries. You are seeing something that supports the knee from the lateral aspect. Can you label this structure? Iliotibial tract. Exactly. This is nothing but a thickening of the deep fascia of the thigh. What is the name given to the deep fascia of the thigh? Fascia lata. So this iliotibial tract is a thickened portion, thickened part of fascia lata that provides lateral stability to the knee, in addition to the fibular collateral ligament. How? By two muscles pull this iliotibial tract from above to provide lateral stability. Which are the two muscles attached to the iliotibial tract? You can see this muscle. Part of this muscle is attached to the iliotibial tract. Which muscle it is? And which muscle is this one? Tensor fascia latae. So these two muscles, when they contract, pull the tibia, this iliotibial tract upwards, thereby maintaining the lateral stability of the lateral aspect of the knee. What is the significance of knowing this area? Okay, that is the site of injection. I am showing you that area repeatedly because you should choose the right site. In post-polio contracture, this iliotibial tract is involved. Iliotibial tract undergoes contracture in post-polio cases. What will be the position of the limb in post-polio contracture? This question has been asked previously in entrance exam. All India, AIIMS, I don't remember. When the iliotibial tract is shortened due to contracture in polio, the hip and the knee will be flexed, will be in flexed position. Both the hip and knee will be flexed. What is the treatment? Divide the tract to prevent these two deformities. polio contraction. So anterior cruciate ligament prevents the anterior dislocation of the tibia. So here anterior dislocation has occurred, therefore it is definitely due to injury to anterior cruciate ligament, no doubt. Only one statement among the four is correct. Which is that one? Number 2. Number 4. Number 2, number 4. Anybody for number 3 and number 1? The cruciate ligaments of the knee joints are intracapsular and intrasynovial. What is your opinion? Look at this picture. This is the upper end of the tibia. You are seeing the large medial meniscus and a small lateral meniscus. This is the anterior cruciate ligament. This is the posterior cruciate ligament. And this is the capsule of the knee, the white color structure, capsule of the knee. Definitely these two ligaments are within the knee joint and inside the capsule of the knee. Therefore, they are intracapsular. You see the synovial membrane here, and this is the synovial membrane covering the joint, inside covering the inner surface of the capsule, and this is the synovial cavity filled with synovial fluid. Now tell me whether these ligaments are intrasynovial or extrasynovial. Extrasynovial. They are outside the synovial cavity. They are not bathed by synovial fluid. Though they lie within the joint, they lie outside the cavity. Definitely within the capsule, inside the capsule. Intracapsular but extrasynovial in position. Look at this. Which cruciate ligament is this? Let me see whether he could label it properly. Yes, because it extends from the anterior end of the tibia. Which cruciate ligament is this? Posterior cruciate ligament. Now, a person walks up the hill or walks down the hill. Person walks up the hill or walks down the hill or walking upstairs or walking downstairs. These cruciate ligaments play an important role in maintaining the position of the joint. When we walk down the hill, it is the femur that is going to be displaced. When we walk up the hill or walk down the hill, it is the femur that is going to be displaced, not the tibia, because the tibia is fixed to the ground. Foot is on the ground, tibia is fixed along with that. It is the femur that has a tendency to be displayed either forward or backward when we climb up the hill or climb down the hill. In this question, the person is climbing down the hill. Is that the one given in that question? Okay. The person is climbing down the hill. The center of gravity of the body is in front of the person. There is always a tendency for the femur to be displaced forward. The femur is trying to be displaced forward because that slope is there. He is climbing down, getting down. And this forward displacement of the femur is prevented by which cruciate ligament? As far as femur is concerned, it is the posterior cruciate ligament that prevents anterior displacement of femur. So which ligament plays very important role when a person walks downstairs or walking down the hill? Posterior cruciate ligament. Suppose a person walks up the hill like this. The center of gravity of the person is behind. There is always a tendency for the femur to be displaced backwards. The femur is trying to displace backward. Which ligament is going to prevent the backward displacement? It is the anterior cruciate ligament. So this ligament plays an important role when a person walks up the hill. So posterior displacement of the femur is prevented by anterior cruciate ligament, and anterior displacement of the femur is prevented by posterior cruciate ligament. It is just the opposite of what we have seen in relation to the tibia. That you should know. This is how the popliteal pulse is felt. The knee must be flexed to feel the pulsation of the popliteal artery. You know why? The deepmost structure in the popliteal fossa is the popliteal artery. If the knee is extended, the fascia in that area becomes taut. Therefore, you won't be able to dip your finger to touch the artery which lies deep. On the other hand, if the knee is flexed, we can easily dip our hand and we can feel the artery to feel the pulse. So this is how the popliteal pulse must be felt. The knee must be always flexed. Extended knee, you won't be able to feel the pulse. If you do so, you may come to an erroneous conclusion that the person is having peripheral vascular disease. The problem is with you, not with the patient. The soleus muscle takes origin from the tibia and fibula and is fused with the gastrocnemius, and the common tendon that is formed from these muscles, called the tendoachilles, is inserted into the calcaneus. So this muscle begins from the tibia and fibula. It has no origin from the femur. It does not cross the knee joint. Can it act at the knee joint? So soleus is not a flexor of the knee. It is only a powerful plantar flexor of ankle. We have seen a triceps muscle in the upper limb. Do we have a similar muscle in the lower limb? Yes, we have. That triceps is called triceps surae. We have seen triceps brachii in the upper limb. Here we are seeing a triceps muscle, triceps surae. What is it? We haven't heard of such a muscle, you may think. The two heads of the gastrocnemius and the soleus which is fused with it are together known as triceps surae. It is also three heads, that is why triceps, two heads of the gastrocnemius and the soleus fused with it, from which a common tendon arises, that is our Achilles tendon. So which is incorrect in this case? This is the only true statement. Okay. Oh, I'm realizing some of you might have seen this before. For others who haven't seen, see the most modern car with all luxuries inside and outside. Front view, rear view, front panel with all amenities. Look at a very large monitor, two pull-outs here, speaker, top glass, can be made opaque also. You can use the pull-out for purposes like this. Plus this also. This is our car. The driver is here quite cheerful. We Indians know how to make use of all these things. Okay. A true statement about the popliteus is only one statement about the popliteus is true. Number 1 and 4. How can you choose 2 simultaneously? Well, is it intracapsular in its origin? Yes, that is the only true statement. We have seen 2 muscles having intracapsular origin. One in the upper limb, our long head of the biceps, and the other in the lower limb, our popliteus. It takes origin from the popliteal surface of the femur, not correct. You see the, okay, here is the tendon of the popliteus, well within the knee joint. You can see the capsule here. So it is inside the capsule, intracapsular. You see the popliteal surface of the femur. Does it give attachment to the popliteus? No, this is the popliteus. It is attached to the lateral condyle of the femur, not to the popliteal surface of the femur. It forms the floor of the popliteal fossa, not the roof. It forms the floor. It laterally rotates the femur to unlock the knee joint, or when the thigh is fixed, when the tibia can be moved, when the foot is off the ground, it can rotate the tibia medially. The net effect will be the same. You can, for unlocking the knee joint, you can either rotate the thigh laterally or rotate the leg medially. Both will have the same effect. You do it like this, unlock it, the opposite direction. So this is the only true statement. Bursa and Serena. Anserine means goose. Goose bursa. It is related to 3 tendons. Which one you want to eliminate from the list? Popliteus. Look at this bursa. Anserine bursa is seen on the medial aspect of the knee, under cover of 3 tendons. This is the semitendinosus, this is the gracilis, and this is the sartorius. The gracilis is in the middle, sartorius is in front, semitendinosus behind. There is a tip used to remember these 3 muscles. We have already seen a layer between 2 majors in the upper limb. Here we are seeing a girdle between 2 surgeons. Sartorius, semitendinosus, surgeons, girdle, gracilis. You know the other peculiarity of these 3 muscles? Sartorius is a muscle of which compartment? Anterior compartment. Semitendinosus, posterior compartment. Gracilis, medial compartment. So all 3 compartments, one muscle from each compartment comes closer to the muscles of the other 2 compartments to gain insertion into a common place. 3 muscles from 3 compartments come to a common place, meet at a common place, and are inserted here. This is the peculiarity. And the attachment of these tendons in relation to the bursa resembles the goose foot. Therefore, the term pes anserinus is often used. Look at this. This is the goose foot appearance. This is the bursa. This is the gracilis in the middle, sartorius in front, semitendinosus behind. This appearance, which resembles the goose foot, is known as pes anserinus. We have heard a similar term in one more place in our body. The 5 branches of the facial nerve also resemble the goose foot, to which also the term pes anserinus is used. Pes means foot, anserine, goose. So popliteus. Number one. See, when a person is in shock, hypovolemic shock, all superficial veins are collapsed. It's not that easy to see the vein to give intravenous infusion. Similarly, in young children and also in obese individuals, superficial veins are not easily visible. In such situations, we can always locate the great saphenous vein to start intravenous infusion. It is a life-saving procedure in a person having hypovolemic shock. We can give blood transfusion also. Intravenous fluid can be given by cannulating the great saphenous vein. For that purpose, we must know where to find this great saphenous vein. Which one is the right answer for this question? Any idea? Number one, in front of medial malleolus. Perfectly correct. Look at this. Here is the medial malleolus, and you can see if you make an incision just in front of the medial malleolus, the vein can be located. You can cannulate this vein. Very easy. While making incision and isolating this vein, care must be taken not to damage this nerve. Which nerve? We have seen this nerve right from the root of our leg, root of our lower limb. Yes, saphenous nerve. Accidental damage to this nerve may produce pain along the medial border of the foot. Even if the nerve is damaged, don't take it so seriously, because if you are treating a life-threatening case, even if a cutaneous nerve is damaged, does not matter, because life is more important than a cutaneous nerve. What is the relation of the short saphenous vein to the lateral malleolus? What is the relation of the short saphenous vein to the lateral malleolus? It runs behind the lateral malleolus, unlike the great. There is a damage to the tibial division of the sciatic nerve in the gluteal region. Which of the following deficits is most likely to result from this injury? Difficult to find out the right answer for this question. Number 5. Okay, now we will see the situation. First we will see the sciatic nerve. This is the course of the sciatic nerve, surface marking. It begins from here, runs in the middle of the thigh. At the upper angle of the popliteal fossa, it divides, terminates by dividing into two. This nerve is the direct continuation of the sciatic. It is in line with the sciatic nerve. Which nerve? Tibial. The other one deviates from the popliteal fossa. It runs towards the lateral aspect of the popliteal fossa and leaves the popliteal fossa by winding round the neck of the fibula. Which nerve it is? Common peroneal. Okay, we will see the nerve again. This is the greater sciatic foramen through which the nerve comes out of the pelvis. Somewhere here it divides into two branches. This is the tibial nerve and this is the common peroneal nerve. What happens to the tibial nerve? You trace it down, it goes into the posterior compartment of leg. Look at this, deep to the gastrocnemius and soleus. So this is the nerve of the posterior compartment of leg. How many compartments are there in the leg? Yes, just like we have seen in the thigh, the leg also has 3 compartments. Anterior, posterior, instead of medial here, it is lateral compartment. What is the other name given to the lateral? Peroneal compartment. So each compartment has its own nerve, just like we have seen in the thigh. Leg also has 3 nerves. Each compartment has its own nerve. We have seen the nerve of one compartment now. The tibial nerve goes to the posterior compartment. Now let us follow the common peroneal nerve. Okay, this is again to show you the tibial nerve in the posterior compartment of leg. This nerve, after entering the compartment, supplies all muscles in that compartment without leaving anything. Now we will follow the common peroneal. The common peroneal nerve winds round the neck of the fibula here. Then what happens? Soon divides into 2 branches. This one is the deep peroneal nerve. It runs deep to the muscles in the anterior compartment of leg. So this is the nerve of the anterior compartment of leg, deep peroneal. Why it is called deep peroneal? Because it runs deep to the muscle. Does not innervate the skin over there. But however, it becomes cutaneous somewhere here in the first interdigital cleft. Now which is the other branch? Superficial peroneal. It runs in the lateral compartment of leg, also known as peroneal compartment of leg. Why it is called superficial peroneal? Because it runs superficially, not only supplying the 2 muscles in the compartment, but also skin over the lateral aspect of the leg and also most of the dorsum of the foot. So the cutaneous nerve of the lateral aspect of our leg and most of the dorsum of the foot is superficial peroneal. It is of course a mixed nerve, supplies 2 muscles in the lateral compartment, because there are only 2 muscles in the lateral compartment, which are the peroneus longus and brevis, and both these muscles are supplied by the superficial peroneal nerve. That is how all 3 compartments of the leg get their nerve supply. From 2 nerves, 3 nerves arise. From a single nerve sciatic, 2 nerves arise. Of the 2, again 1 divides into 2. So that way 3 nerves, 1 nerve goes to each compartment. Nerve of the posterior compartment, tibial. Nerve of the anterior compartment, deep peroneal. Nerve of the lateral compartment, superficial peroneal. Now let us see the action of the muscles of these 3 compartments. What is the primary action of the muscles of the anterior compartment of leg? Dorsiflexion. You pull the muscles in the anterior compartment of leg here, the foot will be elevated. Similarly, you pull the muscles in the posterior compartment of leg upwards, what will happen? Foot will be depressed, plantar flexion will occur. The muscles of the lateral compartment produce eversion of the foot. These are the primary actions of the 3 compartments. Now let us see one more picture. This is the area where the nerve becomes cutaneous. Which nerve? Deep peroneal nerve. This is just to show you the cutaneous innervation provided by the members of common peroneal nerve family. This area is directly innervated by common peroneal nerve through its branch lateral cutaneous nerve of thigh. The rest of the grey colored area of the leg and the dorsum of the foot innervated by superficial peroneal nerve. The lateral border of the foot is innervated by sural nerve via peroneal communicating. Peroneal communicating via sural nerve. Peroneal communicating is a branch of the common peroneal only. The first interdigital cleft by the deep peroneal nerve. So, anterolateral aspect of the leg and most of the dorsum of the foot are innervated by the members of common peroneal nerve family. Okay? Now let us see. This is again to show you, reinforce. This is the area supplied by the lateral cutaneous nerve of calf, and here is the superficial peroneal running down, and this is the area first interdigital cleft where the deep peroneal now becomes superficial. So, a penetrating injury has damaged the tibial division of the sciatic nerve. It is equivalent to damage to the tibial nerve itself. Okay. Now we will read the choices. Inability to abduct the lower limb at the hip joint. Which muscles are responsible for abduction of lower limb at the hip? The gluteus medius and minimus. They are responsible for abduction and medial rotation of the thigh. That is why they are called muscles, walking muscles. Muscles responsible for walking. Abduction and medial rotation of the thigh are required for walking purpose. Which muscle is required for running purpose? Why? Because for running, extension at the hip should occur. Only then running is possible. That is why in all athletic events of walking, the athletes are using only the gluteus medius and minimus. That is why they walk in a peculiar way. Have you observed they are walking like this? The moment they use their gluteus maximus, they will be disqualified because it is equivalent to running. Yes, they are supposed to use only their medius and minimus. Abduction and medial rotation only are permitted at the hip joint. Another interesting thing is that elephants can only walk, cannot run, probably because of absence of gluteus maximus. However, that is why that the gluteal region is not that prominent in elephants. However, their walking speed is much greater than our running speed. One side elephant going to walk, other side human being, runners going to run. Elephant can easily win the match. They can easily catch hold of us. They cannot run, they can only walk at a great speed. So abduction of the hip means hereafter you should remember two muscles, medius and minimus. That is why they are called walking muscles. Now you can eliminate number 1 because gluteus medius and minimus are supplied by superior gluteal nerve. Here injury has occurred to the tibial division of sciatic. Loss of sensation on the dorsum of the foot, we have already seen most of the dorsum of the foot is innervated by common peroneal nerve and its members, branches. Loss of sensation over the anterolateral aspect of the knee, that is by the common peroneal nerve directly, the lateral cutaneous nerve of calf. Weakness in extension of the knee. Extension we know, extension of the knee means quadriceps femoris means femoral nerve. So it has nothing to do with the tibial division of the sciatic. What is left now? Yes, that is tibial nerve supplies all muscles in the back of the leg. They are responsible for depressing the foot. That is plantar flexion. So the person is likely to have weakness in plantar flexion at the ankle joint. We shall stop here and continue the rest of the questions. We have some more questions in the next class along with thorax and embryology. See, before attending the classes hereafter, you should come prepared. If you come totally blank, that will not help. You should have some idea about the chapter that we are going to discuss. Only then it will be easy for you to follow quickly. If at all you are not able to read all these things, at least see some diagrams in the textbooks, any textbooks that you follow, and come prepared. That will be easy. That is what I expect from you from the next class onwards. topic, thorax and embryology. If not embryology, that other related topics like osteology and histology also will be covered along with thorax, if you are not able to complete. You prepare two topics, thorax and developmental anatomy, embryology.